Good morning. We're going to go ahead and get started. I know people are trickling in because of the weather. Thank you for braving a snowstorm in November in DC. I mean, that's really crazy, but we really appreciate you being here. I'm Krista Droback with the Alliance for Connected Care. We are honored to have a great lineup today, and our goal is to help educate about all of the different policy changes that have happened in telehealth, and there have been quite a few in the last 18 months. So we are going to hear from our distinguished guests from Capitol Hill and from the administration. And in between, I'm going to do a slideshow on all the changes, but then we're going to have a discussion towards the end of the day because I'm hoping that there will be lots of questions. But so that's just the way the agenda worked out. So hopefully you can stay for the Q&A at the end. So kicking us off today is Congressman Bill Johnson. He is the incoming co-chair of the Telehealth Caucus and a member of the all-important Energy and Commerce Committee in the House. He just was reelected to his 5th term in Congress, and he represents Eastern and Southeastern Ohio. He is been a champion of telehealth for as long as I've been involved in this. And he actually was part of the Telehealth Caucus before the Telehealth Caucus was a formal caucus. So we are very excited to hear from him. He's responsible for many of the wins that we've had this year, including he and Congresswoman Matsui introduced a really important bill that led to the passage of what we're going to talk about later, but basically the coverage of substance abuse in Medicare fee-for-service. So I'll turn it over to Congressman Johnson. Thank you.
Well, thank you, Krista, and it really is good to be with you. Telehealth is an important focus area for me. Both of my college degrees, my undergraduate and graduate degrees, are in computer science, and I often give an analogy, and you may be aware of this, but it was 2,500 years from the discovery of the geometric properties of the right triangle, when Pythagoras discovered all that stuff, the Pythagorean theorem that we learned about in 7th grade algebra and all of that. 2,500 years before those properties were used in modern architecture. Today, you can't get by without it. Sine, cosine, tangent, all that stuff that architects use to build the fabulous buildings and stuff. 2,500 years. We only started doing computing technologies, think about it, back in the 40s and 50s in secret, 60s and 70s commercially, 80s and 90s when the computers came into the homes. So we are babies at this. You think about where we could be once we really get our arms around the technology. And I'm a mule farming plowboy. I mean, when the Air Force told me that I was going back to school to get a degree in computer science, I thought they were crazy, because in 1977, no one knew what a computer was. We knew there was a computer building, and there was a cipher lock on the door, and you talked to somebody that looked like they were a doctor because they were in a white coat, and you never got to see anything regarding the computers. And so I had no idea what I was getting myself into. But so grateful that I took that journey. We know now that telehealth is not some kind of flash in the pan fad or phase. It is real. I've seen it in action. I'm going to talk to you about that a little bit. We know that it's a powerful tool for improving access to health care for all Americans, whether they live in rural areas like Eastern and Southeastern Ohio, where I call home, or whether they live in a big city. I've had the opportunity to see it in action across my rural district, from robots that help seniors stay in their homes and out of nursing homes, to video conferencing tools that allow stroke victims to get the care that they need through consultation with geographically separated doctors to give them the best care possible, because you got to get to a stroke victim pretty dadburn quick, or the damage is done. And I believe that, as I said, that we've only begun to scratch the surface. I know at Nationwide Children's Hospital in Columbus, some of the most unbelievable cardiothoracic surgery done on infants. I stood over the operating table one day back in 2014, I believe it was, and watched a heart surgeon basically dissect the heart of a 10-day-old infant and redo all the plumbing in a procedure called an arterial switch. And those kinds of operations are life-sustaining, because that baby would have died and was on life support from birth, and without that operation would not have survived. But 2 days after the surgery, went home, or came out of ICU. 4 days after the surgery, went home with mom and dad with a brand new heart. We can take that kind of technology and that kind of medical advance into rural America, and heart surgeons in Columbus can be watching on a telehealth monitor, or even remotely through robotics, actually perform the operation. The technology is there. We've just got to go after it. And I know that everybody in this room is a believer, so I realize that I'm preaching to the choir a little bit, but study after study and pilot project after pilot project have assembled a body of evidence confirming telehealth's wide-ranging benefits. Patients with chronic conditions can have a better quality of life if they have access to continuous remote monitoring technology that helps them and their doctors manage their health. I saw a telehealth application from the University, Cincinnati University, actually a hospital in collaboration with Cincinnati University down in Cincinnati. It's a robot that can be placed in a senior's home. You've got a shut-in senior that needs monitoring. This robot can be turned on and off remotely. Go up and sound an alarm and wake John or Martha up and say, hey, it's time to take your blood, stick your finger in a portal, and it does that, and it tests and gives the doctor on the other end the information that they need to see if that patient is okay. When the procedure or when the checkup is done, the robot goes right back into its charging station where it came from, and waits until the next time that it needs to connect with the physician. And all the while, there's a video capability, and the patient at home is talking to their physician. So we're there. Patients and providers can better assist their patients in sticking to a care plan if they can check on them and provide on-demand guidance outside of office visits. Hospitals can better care for patients when they can consult virtually over the internet with specialists around the country or even around the world. And ultimately, payers benefit because regular access to health care and proper management of chronic conditions lower health care costs. And I'm sure you are aware acutely that health care costs are the biggest drivers of our national debt. We just had an election, and I kind of felt bad for my opponent, who was very uninformed. And I know this is not a political speech, but this will set you'll understand what I'm going to say. They asked her a question about the national debt. What would she do to fix the national debt? And she said, well, the first thing I would do would be slash the defense budget, because the defense budget is the biggest part of what the federal government spends. That's what's driving our debt. And so I had to correct that statement when it came my turn to respond, and to let the audience know that no, it is not. What is driving our national debt and continues to drive deficits are the staggering health care costs in America. So we've got a long way to go. The evidence for telehealth is overwhelming. And yet, for too long, the federal government, through Medicare, has put up barriers to expanded use of telehealth. However, I feel that the clouds are starting to break up and there's opportunity for real progress. Let me give you a few reasons why I'm so optimistic. The Trump administration, through CMS, has plowed ahead with removing some of these barriers for new uses of telehealth. You'll hear later from CMS Administrator Seema Verma, and I know you'll be encouraged by her vision for how telehealth can improve our healthcare system and how CMS is working to make that a reality. Under her leadership, CMS has gone to bat for providers and for patients to adopt creative telehealth solutions. I won't go down the laundry list this morning because this early in the day, but I know you're going to be talking about some of these later in the program. But I will say that I'm greatly encouraged by CMS's dedication and focus on this front. Other agencies are also moving ahead with initiatives to expand telehealth as well. Commissioner Brendan Carr at the FCC is spearheading the Connected Care pilot program to increase access to connected health technology for patients outside the four walls of a doctor's office or clinic. At USDA, Assistant Secretary for Rural Development Ann Hazlett has made it a priority to ensure that rural America is not left behind in the push for better use of technology in healthcare. So on many fronts, the Trump administration is going to bat for telehealth and breaking down some of the barriers. But we know that those efforts, while all encouraging and necessary, require strong support from Congress. And I'm proud to say that in that area, we've also delivered and made some progress. As someone who has preached the gospel of telehealth now for several years, I'm encouraged by the gathering awareness and support of telehealth, particularly among my colleagues. That support manifested itself, as you heard from Krista, in the formation of the Congressional Telehealth Caucus last year. My colleagues and I on the caucus have worked hard to advance telehealth legislation, and we've had some notable successes. During the 115th Congress, which we are now wrapping up, we passed legislation to expand the use of telehealth to dialysis patients in their homes, for stroke patients, and I mentioned that a little earlier, and seniors who use Medicare Advantage. And I was proud to work on legislation that was signed into law as part of the Support for Patients and Communities Act to address the opioid crisis that would waive the geographic and site restrictions on telehealth for those suffering from substance use disorder. Despite these wins, we've still got work to do. I plan to continue working to pass legislation, which I introduced this session with my colleague, Representative Doris Matsui from California, that would allow the geographic site restrictions to be lifted for all Medicare codes. So we're trying to go big, and we'll see where that takes us, but it's a start. There's also ongoing work to ensure that, and let me caveat this, the providers want it, the technology is there. The problem is policy and the regulatory framework. It's the licensing, the payments, and those kinds of things. There is absolutely no reason why in Timbuktu, rural Appalachia, you can't get access to a world-class heart surgeon over telehealth. There's no reason why you can't do that. The technology is there. The providers want it. It's all an administrative regulatory issue. There is also work ongoing to ensure that as we move away from fee-for-service to more value-based arrangements, our existing laws and regulations must be updated to allow for innovation and creativity in healthcare delivery, including telehealth. We also should ensure that new laws and regulations are flexible enough to accommodate for future developments in technology and care delivery. Those are the unintended consequences of legislation. We don't want to inadvertently throw up a barrier that doesn't already exist, and we're trying to break those that do exist down. Another fundamental component of telehealth is increasing the coverage of our broadband infrastructure to every corner of America. In too many rural communities in my district and around the country, broadband is unreliable if it's available at all. I can't tell you how many communities I represent where young people have to go to a Tim Hortons or a Panera Bread or to a public library someplace in a neighboring community where they can get access to Wi-Fi so that they can do their school projects. Businesses will not come in to rural areas because they can't get access to manage their customers and their suppliers and help educate their employees. So if you don't have high-speed internet connectivity in your community, it's a serious disadvantage. But it's no longer a pie-in-the-sky luxury. It's essential for everyday activities. Many rural residents have 30 or more miles to drive to see a doctor, to be admitted to a hospital. In an emergency, 30 minutes of wait time could mean the difference between life and death. At other times, it deters rural residents from obtaining preventive care, ultimately increasing the nation's health care costs. Telehealth programs bring advanced medical care to these remote areas, but in most cases, such programs aren't viable without broadband connection. I am and will remain a passionate advocate for broadband access and erasing the digital divide. The possibilities for telehealth to transform health care delivery for Americans everywhere are many, but they are only just the beginning. I encourage you to remain engaged on this important issue as we start a new session of Congress in January. I'll continue my leadership on the issue, but there are lots of new members, both Republicans and Democrats, to bring to the table to support the cause, and that's an area where you play an important role and can be helpful. Thanks again for inviting me to speak today. Please consider me an ally, and if you ever want to talk in more detail, please stop by my office in Longworth. I'll be glad to chat with you. I can talk about this stuff for days. Krista's giving me the hook over here to the left, so I'm going to, I get that hint. So I'm going to step down, but thanks so much for having me this morning. Krista, thank you very much.
We're honored to have Congresswoman Anna Eshoo here, and so I want to turn it over to Chris O'Dell, a board member for the Alliance, to introduce her.
It is my honor to introduce Congresswoman Anna Eshoo, who was recently re-elected to serve her 14th term in Congress representing California's 18th Congressional District, which includes Silicon Valley and Stanford Medicine. She serves on the House Committee on Energy and Commerce and recently announced her bid to chair the Subcommittee on Health, for which we could not be more supportive. Working at Stanford Healthcare, I've had the opportunity to see firsthand the commitment and dedication that Congresswoman Eshoo has put forth to expand access to healthcare, including through telemedicine and remote monitoring. Congresswoman Eshoo has a keen understanding of the healthcare consumer and the innovative solutions we can use to make healthcare more accessible and affordable. The Congresswoman has authored 40 bills, more than half of which are healthcare related, and was recently a co-sponsor of the FAST Act, which aimed to lift the Social Securities Act originating site restrictions on telestroke services. That legislation was included in the Bipartisan Budget Act of 2018 and signed into law last February. In an Energy and Commerce hearing on broadband infrastructure earlier this year, Congresswoman Eshoo made the case for investing in rural broadband to expand telehealth capabilities to those who do not currently have access to it. We've recently seen the FCC take action on this issue by rolling out the Connected Care Pilot Program and the 5G FAST Plan. On behalf of Stanford Healthcare and the entire Alliance for Connected Care Board, I'd like to thank Congresswoman Eshoo for her tireless work on these issues. We look forward to her continued success in the next Congress. So without further ado, please join me in welcoming Congresswoman Anna Eshoo.
Well, good morning, everyone. That's better. That's better. Everybody's awake and dry. It's so lovely to come from California for the weather in Washington. Wow, it is really mean out there. Chris, thank you for your very generous introduction. It's wonderful to be with you. Thank you for inviting me. I also want to acknowledge Andy Coe, who is head of government relations at Stanford. Where's Andy? Right there, seated. Thank you. It's always good to see you. It's a nice welcoming party in the lobby. This is an important issue, and I'm really pleased to be here this morning and to talk about where we are with telehealth, some of the different moving parts of it, how we can increase its use, because it really is a very important element in healthcare for people across our country. I think that telehealth is at a critical juncture in our country. Providers across the country, including many of you, are successfully incorporating telehealth into your patient care models. Private plans are offering coverage for these services, and portions of Medicare are following. But there are barriers and there are challenges to full adoption of telehealth for all patients across providers and payers. Telehealth, and I'm preaching to the choir, brings a broad range of services to patients who otherwise would not have access to their physicians, and it's increasing prescription adherence, simplifying follow-up visits, and improving outcomes. And those last two words are very important: improving outcomes. In Silicon Valley fashion, Stanford Healthcare is exploring ways to bring new, innovative, and high-quality technologies and services to patients more quickly. Stanford has successfully incorporated telehealth in post-operative care, primary care, cardiology, psychiatry, and behavioral health. So this is really being integrated across all of these services. The quality of these services is consistent with Stanford's reputation. If you think I'm bragging, I am. I'm very proud to represent them. Under Stanford's model, existing patients have the opportunity to remotely manage their diabetes. Cardiology patients can track their blood pressure and meet with nutritionists over video conference, and patients recovering from surgery can follow up with their surgeons without having to brave Silicon Valley traffic for a check-in. And boy, our traffic is really something. During the deep recession, you could get anywhere within 15, 20 minutes. But our unemployment rate is somewhere around 2%. So traffic is very heavy. Stanford demonstrates that when telehealth is offered, patients want to use it, and they do. They've been successful, I think, in part because the state of California has set up a system that promotes the adoption of telehealth, and now has a telehealth coverage parity law requiring insurance plans to cover telehealth services equal with in-person services. So that is an important contributor to it. California's coverage parity law does fall short of reimbursement parity, but even without the statutory requirements, many private insurance companies do cover these services with reimbursement parity. So that has really energized the issue, but there's still a ways to go. We never really get quite there in our country, but once some of the steps are taken, they're like building blocks, and I think that this is a very important model for other states as well. As more data is collected about the impact of coverage parity and reimbursement parity on telehealth implementation, Congress should examine this as a model to expand access to telehealth. One of the biggest barriers to telehealth adoption is the disparity between coverage in Medicare Advantage and Medicare fee-for-service. Congress passed, and I think that Congressman Johnson mentioned this when I was coming in the door, passed the bipartisan budget agreement of 2018 in February of this year, enacting major changes for telehealth policy, which are now going through the formal rulemaking process. When the rule is finalized, it will allow Medicare Advantage plans to cover telehealth services and offer them as a standard benefit. This will enable patients to choose between telehealth and in-person services regardless of where patients live. These changes affect Medicare Advantage only, not Medicare Part B or traditional Medicare fee-for-service. Under traditional fee-for-service Medicare, telehealth will continue to be offered with restrictions on the originating site and only in rural settings. So there's a split. It's not really a complete, it's really not a complete picture. This means that beginning in 2020, there will be a divide between the services and benefits offered to Medicare Advantage patients and those in traditional fee-for-service Medicare. This will result in a patient's insurance plan dictating what's new, right? What services they're eligible to receive rather than what's most appropriate care for patients. This is a barrier that Congress, I think, should address by removing the originating site requirement and rural location requirement, so all Medicare beneficiaries, regardless of their insurance plans, have access to these services. So we still have some work to do on this. While there is currently limited research on the downstream savings with adopting telehealth, we do know that with improved access and increased utilization of primary care services, healthcare costs go down and the health of our country improves. In addition to the challenges affecting telehealth adoption in healthcare, and I know that Congressman Johnson mentioned this, our nation's telecommunications infrastructure is another barrier. I'm a member of the Telecommunications and Technology Subcommittee, and this is an area that I'm more than familiar with and have worked very hard to expand broadband access across our country. All chronically ill patients really should have access to their doctors from their homes. But without high-speed internet, these services will still be out of reach for these patients. And there are a lot of Americans that are out of the loop. Today, 1/3 of Americans, I don't know how many people really know this. Once you know it, you have a deep appreciation for it. 1/3 of Americans don't have the level of internet access considered to be the minimum connection rate by the U.S. government. So they can't Skype or video conference with their physicians through these programs. So they're completely left out of it. They're completely left out of it. I've introduced a package of bills with the specific goals of expanding access, reducing costs, and increasing consumer choice. Even in urban and suburban areas, most consumers really don't have a choice, i.e., we don't have competition, which is another spur in my saddle. I offered legislation, it's called Dig Once, and what it does, it passed earlier this year after I think at least 3 Congresses of offering it. I asked a senior member of the Transportation Committee about it and urged his support of it, and he said, it makes so much sense that it hasn't been done. Well, it finally was. The Dig Once Act passed earlier this year, and what it does, it mandates that when infrastructure, roads and highways are built using federal funds in areas with a demonstrated need for broadband service, that the broadband conduit pipes are to be laid down at the same time rather than tearing up the roads after they've been built. So, I mean, it really is common sense. This is going to significantly reduce costs for providers to enter these markets, and that's very important because they complain about not being able to get into these markets. I've offered the Climb Once Act. That similarly removes federal barriers to installing and updating internet conduit that is hung on utility poles. Both bills are bipartisan, and they don't cost a dime. So I'm hoping that in the new Congress, we can get this Climb One Act done as well. So many areas of rural America still lack broadband, but the pole infrastructure is already there. That was done by many Congresses ago, where the utility poles were built and have carried telephone service to people across our country. So the infrastructure is already there. So by making it easier to simply update that infrastructure, we can bring down the large numbers of Americans without broadband considerably. This would really boost that effort. And the third bill I introduced empowers localities to take matters into their own hands. The Community Broadband Act enables city-operated broadband initiatives, and there are several successful models of that already in the country. So together, these bills provide solutions for Americans to get connected to their health providers and are important to expanding the adoption of telehealth. Congress needs to continue to improve access to health care, and of course, telehealth is a critical element to ensure every American can have access to high-quality care. I want to salute you for the work that you're doing to develop not only statutory and regulatory recommendations. That is, it really is invaluable because you, both as individuals and a group, understand how policies play out in your lives and the lives of your patients. So I look forward to, just as Congressman Johnson said, to working with you, to be a partner with you in expanding access to the number of services, and there are so many that are offered, and the number of patients that would benefit by being served by telehealth. So thank you for inviting me here this morning. I was more than willing to brave the lousy weather. Again, thank you for the work that you're doing. It's so important because the marriage of telehealth services and universal health care for people in our country cannot really be brought together unless they are. And so I don't think that the challenges that are there are really all that difficult to get beyond. I think that there's a very, very solid case to be made for this. And the Energy and Commerce Committee, I think, is important to examine as a whole, regardless of what the ratios are going to be. And of course, I'm thrilled about what the new ratios are going to be relative to the two parties. But when you examine, we don't know who the new members are going to be, appointed to the committee. But more than half of the Energy and Commerce Committee have members that represent either total rural areas or have rural in their districts. So there's a real opportunity on both sides of the aisle for you to make inroads in this. So I just wanted to put that out there as a little tantalizing nugget. And I've said to those members, you could rule the world on this committee. Know thy power. Know thy power. but you should know your power with that observation as well. So thank you for having me here this morning. I look forward to working with you. I think we have a lot of exciting things that are going to be taken up in the new Congress. And as a woman that was elected in 1992, that year, I think, well, many of you are too young to remember, but there are others that do. It was dubbed the year of the woman. And so I always said, well, they only meant it for 1 year. But now it's the year of the woman 2.0. And so we have so many new members, so many women coming into the Congress, which is refreshing. They come in with extraordinary backgrounds, jet fighter pilots, those that worked in our intelligence services and the CIA, those that were part of the State Department and diplomacy, those that ran very large nonprofits. So that experience and background really is high value added to the Congress of the United States. So we have a lot to look forward to, including working with you. So thank you for having me here this morning. It's an honor. Thank you.
I'd like to welcome Lisa Malloy, the head of U.S. Government Relations for Intel, one of our sponsors for today, and also a board member of the Alliance.
Thank you, Krista. We are really happy to be here today and to help sponsor this great dialogue. I am so pleased to introduce newly reelected and next chairman of the Senate Commerce Committee, Roger Wicker. Senator Wicker has been a tireless champion for telehealth and responsible for much of the progress made in Congress over the last 2 years. In fact, it was a hearing that he held as chairman of the Subcommittee of Communications, Technology, Innovation, and the Internet that got the ball rolling for critical legislation that is now law. That hearing in April 2015 rallied his colleagues for a 2-year effort to pass legislation improving reimbursement for telehealth and Medicare and pushing for more broadband funding. Joined by his Democratic colleague on the subcommittee, Senator Brian Schatz, Senator Wicker's work culminated in the development, introduction, and passage of key provisions of the Connect for Health Act, which is one of the successes that we're talking about here today. Senator Wicker was also an original co-sponsor of the E-Treat Act, which lifts telehealth reimbursement restrictions for treatment provided to Medicare beneficiaries suffering from substance use disorders and co-occurring behavioral health challenges. The E-Treat Act was included as part of the opioid package passed into law last month. We look forward to his continued leadership on this issue and many others as he becomes chairman of the full committee next year. Please help me welcome Senator Roger Wicker.
Thank you. Thank you very much. And I only regret that my dear friend and colleague, Anna Eshoo, scooted out that door as I was coming in this door. She got to the House of Representatives in 92. I got elected in 94. And I've been a lot of places with her and done a lot of things with her. I think she's made some great points that I would reiterate to start with. For one thing, she talked about the weather. I don't. Are you staying in a hotel, or did y'all have to get here? The radio was telling me as we came in that the winter storm is overperforming, and yeah, it's certainly overperforming in Alexandria. It looks beautiful. Maybe a little sleet out here now, but really beautiful, big white snowflakes coming down in Old Town. And yeah, if I were in school, I'd have the day off today. But we're gonna try to finish up our work in the Senate today, and then I'm headed to sunny Nova Scotia to a defense conference, and that ought to be really nice weather. Also, it's sort of ironic. They announced the government announced that government offices would be working today, but employees were encouraged to telecommute and to telework. So that's kind of what we're talking about here today. Anna talked about a number of things, and thank you for that nice introduction also. You know, when I talk about Anna Eshu from California, I've never been to her house, but I sort of think of her as a big city gal. And so it's encouraging to hear someone from the West Coast of California talk about rural areas. And I think I heard her say that there are so many people on her committee, Energy and Commerce, that hail from the great heartland of America, the rural areas. And certainly that can be said for today's Commerce Committee makeup and the Telecommunications Subcommittee makeup in the United States Senate. People like me from Mississippi, and you can look down the row there for me. You got John Thune from South Dakota. You got Deb Fisher from Nebraska. Then over on the other side, we've got Montana. People forget how much rural area is in the state of Hawaii. But Brian Schatz will certainly correct you pretty quick if you think they're all urban. And he's part of the solution, the bipartisan solution that includes members of my committee and also people like Anna Eshu who want to see this work. A couple of things about the reason for this, a couple of things about what we've done in Mississippi. I might mention or reiterate some legislative solutions and then some administrative administrative actions, and then we'll try to get back on schedule here. We have shortages all over the country. And if we're ever going to treat these, now is the time, and telemedicine is the way. I live in one of the most underserved states, regrettably, in the country. We just have a lot of really small towns, and you know, I like living in my home state. I like living in a rural state. I like living in a small town. You want to live in a big town? There's only one in Mississippi. I live in Tupelo, a small town. I grew up in an even smaller town. Hospitals are closing in these rural areas. We've lost 5 recently. More than half of Mississippi's population lives in a rural area, and nearly a quarter of our rural citizens live in poverty. So we have a problem with the density of the population. We also have a problem with our disease. We are the heart belt. We're the buckle, the heart belt. Heart disease, type 2 diabetes, the lowest numbers of health care providers per capita because they can make more money elsewhere. So we have a problem, and we have to, by necessity, we have to think outside the box when it comes to telehealth. So how is the University of Mississippi making telehealth work? For short, I call it UMMC. UMMC, University of Mississippi Medical Center, set out more than a decade ago to expand the reach of its specialized care through telemedicine. Technology allows a specialist in our capital city to consult simultaneously with a doctor in rural hospitals miles and miles away. We have a bold project which we are proud of and which we wish could be expanded. It is the Sunflower County Pilot Program. With an internet connection and an electronic tablet, patients with diabetes in this program are routinely monitored by specialists, leading to good outcomes. These people are healthier, they're hardly ever going to the hospital, and cost savings. The use of telehealth to treat This chronic disease of diabetes virtually eliminated emergency room visits. Eliminated emergency room visits and lowered patients' blood indicators of sugar levels and increased cardiovascular health. Now, we put a human plus on that, but also we've saved a ton of money just in this little project. If we were to increase the number of diabetic patients receiving this type of care, we could save money big time. The Mississippi Department of Medicaid has said that $189 million could be saved each year if only 20% of the state's Medicaid population who suffer from diabetes were to use this technology. If only 20% would use this, we could save $189 million a year. The pilot program in Sunflower County included only 100 participants, and that in itself saved $678,000. So we're tickled with that. Because of our pioneering efforts, UMMC was designated National Telehealth Center of Excellence right there in Jackson, Mississippi. And earlier this month, the Forest County General Hospital in South Mississippi, Hattiesburg, Mississippi, location of University of Southern Mississippi, received almost $500,000 grant from the U.S. Department of Agriculture to purchase telemedicine equipment. So we are on the forefront. We have been for a decade. We need more money. If we could spend a little more money, we could save a ton of money, not to mention making people happier and healthier. So what are we doing legislatively? The introduction has touched on that, and so did my dear friend Anna Eshoo. I introduced the SPEED Act. This is bigger than telehealth. It's just connectivity and streamlining the permitting process. SPEED means streamlining permitting to enable efficient deployment. Have you noticed more and more of our legislation has acronyms now? So it's a SPEED Act, and the idea is to speedily permit process for getting broadband to our rural areas. I think you know that some localities, when you're trying to build out, they see that as an opportunity to hold you up for more money than it should take and to slow you down if you don't pay up. So the SPEED Act is designed to address that. We need to encourage telehealth as a healthcare option. And my dear friend Brian Schatz, who is a real leader in this area, has introduced with me the Connect for Health Act, which tells Medicare and CMS you got to get with the rest of the insurance industry and start making it easier to claim telehealth on your Medicare. And telehealth could be a game changer for chronic disease. The CDC reports that chronic and mental health conditions represent 90%. Chronic conditions plus mental health conditions represent 90% of the $3.3 trillion our nation spends on health care. Did you know that? 3.3 trillion, 90% is either mental or chronic. So we're working on that, and of course we're making the VA more telehealth friendly, and we're using telehealth to treat the opioid and to address the multifaceted opioid epidemic. Briefly, the Trump administration. CMS happily has taken significant steps to advance telehealth. Just this year, the agency has been creative in thinking about what it can do administratively within current statutes to increase telehealth services. This includes establishing payments for virtual check-ins, removing evaluations of a picture or a video, and expanding payments for remote patient monitoring. So we're 10 years into it in Mississippi, but still we're in the infancy of this, and so I guess it's good that you all are here. This is a bipartisan issue. Anna Eshoo is thrilled about the new ratios in the House Energy and Commerce Committee. I can tell you I'll be just as thrilled with our new ratios over on the Senate side. The majority expanded on the Senate side. It evaporated on the House side. But this is an area where we work together. And when I reach across the aisle with folks like Brian Schatz, and I know we're not working on a partisan angle. And when we reach down to the other end of the building with folks like Anna Eshoo and her new chairman, Frank Pallone, we know we will be working on something that just doesn't have to be partisan at all. I look forward to some major changes over the next year and 2 years. And I thank you for coming to Washington and being a part of helping us think through this. Thank you very, very much. Appreciate it.
Okay, a couple housekeeping items. I've been chastised for not putting our Twitter handle on the program, so if anyone would like to tweet, we would welcome it, and it is ConnectWCare. So at ConnectWCare. So we welcome tweeting. I'm not an expert at it, so I apologize for that. So I'm going to talk until Administrator Verma is here, and then so I can talk like an auctioneer, and I will be employing that talent now. But we will have time for questions and a real discussion of the actual deep policy details later in the day. And also couple other housekeeping. We're going to have a good long break, 25 minutes after the administrator speaks. I know this is a long stretch for sitting. And the other thing, I want to thank our sponsors. I forgot to thank our sponsors, Intel, American Well, and MD Live. Thank you for making this possible. Okay, so we're going to have a quick overview here of all of the new developments that have happened we're going to start with remote patient monitoring, and then we're going to go to telehealth. So quickly, this is our board members of the Alliance for Connected Care. And these are our advisory board members. We work very closely with a lot of the patient and advocacy groups around town. So the first thing is the definitions. So when I'm sure all of you know, we say telemedicine, telehealth, virtual care, e-visits. So I'm going to use a couple terms. I'm going to use remote patient monitoring, which is the asynchronous sending of biometric data. So a provider receiving data from a patient, and then telehealth is a virtual real-time visit. So those are the ways I'm distinguishing these two modalities. So remote patient monitoring, previously, and what I mean by previously is 2 years ago, as recently as 2 years ago, we had a really confusing remote monitoring landscape. We had codes for an implantable device. So if you had a pacemaker, your physician could read that data. But if your device was next to your bed, then your physician would not get paid for reading that data. It was very ad hoc, and there wasn't a lot of interest among CMS, Center for Medicare and Medicaid Services staff, in clarifying any of this. And every time we went in to talk with them, we basically got, well, we need more data, we need more evidence, we need more data, we need more evidence. And so we didn't really get anywhere. So there are 3 ways that CMS reimburses for services in Medicare. You can either have a piece of equipment, so that's called DME, durable medical equipment, or you can have practitioner time. That is that's the biggest way that CMS reimburses. So they'll pay a practitioner for the time, and then the idea is that the investment in the medical equipment actually makes sense because they're going to earn it back with their time. And then in our case, they also have beneficiary data collection. So the first thing that happened in RPM payment is in January of 2017, CMS approved payment for continuous glucose monitoring through a DME code. So it was the actual device that they were paying for. But they said you can't get paid for the device if the data gets transmitted through a smartphone or a tablet, which of course the advocates, we kind of were like, why? That's crazy, because why would most of the devices require that and patients need that? So there was a lot of advocacy around this, and this year CMS updated it and basically changed their mind and said, okay, you can use a smartphone. So this was a development in earlier this year. And by the way, these slides will be available on our website. So if you don't want to take up your bandwidth on your phone by taking pictures, this will be available. And after the break, I'll announce the address on our web, the backslash. I think it's backslash. Well, I won't tell you the wrong one. So, that was the first. That was the first big development. Was the DME development. The second development started in 2017 when CMS requested information about potentially unbundling a code. So the way that remote monitoring had been reimbursed in the past was it was bundled. So CMS bundled codes, and then they only pay for one code. And what they did was they bundled a code called 99091 with a care management code. And the sort of philosophy was, well, if you're managing care for chronic disease the way it should be managed, then you should be remotely monitoring. So that's kind of why they bundled those codes together. And we went, and as the Alliance, and I see Robert Jaron here, who's a big advocate, and Sylvia Trujillo from the AMA, we all went in to CMS and said, when Seema Verma came in and said, if you really want to do something right now, unbundle 99091 from the care management code. And they said, well, the physician fee schedule, the draft of the physician fee schedule is already over at OMB. And once it's over at OMB, it's really hard to pull it back and it's really hard to change it. But we said, well, how about just putting down a marker? Just say something about it. And so they put out an RFI as part of the physician fee schedule, asking the community what we thought about potentially unbundling these codes. And there's the definition of the 99091 code, essentially. And if you read it, it is remote monitoring, sending in your biometric data. So what did they do? They unbundled it. We all wrote in and said, this is a great idea. And because they had that marker in the proposed rule, they were able to finalize it in the final rule. And they basically allowed payment to start this year. So January 1st of this year. There's Sylvia. She was instrumental in this too. Starting in January 1st of this year, we were able to start billing for 99091. So I encourage you to, after I talk about the rest of these codes, tell everyone you know, because it's taken a long time for the marketplace to actually figure out that physicians can now get reimbursed for this. So the code is paid about $56.80, 30 minutes of reviewing. That can include time assessing the data from the patient. One thing that's unique about this code, it doesn't require FDA or an FDA approved device, so it can come from lots of different devices from the patient. So there are, I'm sorry if I'm using words that are like physician fee schedule, et cetera. Medicare has different, they have, I think, 7 different fee schedules. So hospital inpatient, hospital outpatient, physician. And this home health rule governs people that administer home health through Medicare. And in this year's home health rule, they said that you could use the 99091 code as part of your cost allocation for RPM. So this is a development from this year related to that 99091 code. So they are continuing to roll it out throughout the Medicare program. So at the same time that CMS was looking at 99091, you may have noticed in the final physician fee schedule, they said, we're going to unbundle this code for the short term. And the reason for that is because the American Medical Association had a advisory group that was trying to develop more appropriate codes. The 99091 code was old and kind of clunky. And so AMA got a group together, and we have a couple of the members of that group in this room. So if you ever had any questions about it, but this was their mission, and they worked really hard to come up with 3 new codes that were, they felt aligned with the way that RPM is delivered today. And so these 3 codes, one of the, I think the key differences is that the time that the physician or other care provider, it's not just physicians, the time they take in training the patient on the device and explaining what it all is, that's actually paid for now. So that's an important distinction, I think. These codes do require an FDA device, so the readings have to come from an FDA-approved device. And these codes also clarified the kinds of providers that can can receive the data and get paid for the data. So so after AMA, the advisory board came up with this, they sent it to the CPT committee, CPT approved it, then the RUC, which values the codes, approved it, and then it has to go through the physician fee schedule process. So it was a long process, but CMS approved these codes in the final rule, and they start January 1 of next year, so January 1, 2019. So again, tell everyone you know, because we need to get word out that this is now an available reimbursable service. So there again is the summary. I think we have, the payments are here underneath. And again, these are going to be posted on our website if you're interested in the actual payment that you receive for each of these codes. Okay, so that's remote patient monitoring, and again, we'll have time at 2:30 to get into more detail if you'd like. Telehealth. So telehealth. The reason CMS was able to do so much and advance the ball so far in remote patient monitoring is because the statutory requirements that are barriers do not apply to remote patient monitoring. So they were able to just go ahead and make major changes that essentially created the remote patient monitoring benefit. That is not the case for telehealth. Telehealth has a restriction that is embedded in the Social Security Act, Section 1834M, that basically says you can't get reimbursed for telehealth if the patient is not in a originating site. And they actually listed the originating sites in the statute, so there was no way for them to evolve over time. So for example, you can't be in a retail clinic. You have to be in a hospital or a physician office, a rural health clinic. And the problem was it sort of defeats the purpose of telehealth, right? You're supposed to be able to be at home or with your caregiver. And so they also set up an annual process. So they said, okay, you can do telehealth, but it has to be an originating site in a rural area, and you can't do it for all of Part B Medicare. And Part B Medicare is the physician fee services. They said, we're going to set up a system where you have to get the code approved with a telemedicine modifier. So you can't actually just do any Part B service. You have to basically go and look up the codes. And there aren't very many codes, and in part there aren't many codes because people don't submit codes because there are all these barriers anyway. So kind of what's the point of going through the work to get the codes approved? So it's a somewhat short list. Behavioral health is probably the biggest benefit of what already exists in these codes. But that has been a restriction. So as a result of this, there has been in the past no coverage of telehealth for about 80% of Medicare beneficiaries, and no coverage from the home. And there are many Part B services that don't have codes or telemedicine modifiers. And again, doesn't include anything that is non-physician service, so no physical therapy, occupational therapy, speech therapy. So as a result, this is from 2016. It hasn't changed very much, but it's kind of funny because the telehealth expenditures in Medicare are so small that the Excel was not going to let me make this chart because basically it was like so minuscule you can't even see it. So, you know, out of a $990 billion program, we have 28 million in telehealth services. So, okay, so we have been at this. I've been at this since 2013. Others in the room have been at it longer. But we tried all these legislative vehicles. We tried, you know, macro, 21st century cures, chronic care. I mean, we basically were going to Congress and saying, here's a moving vehicle on Medicare, put in something, you know, put in a change on telehealth, put in a change on telehealth. And they said a couple things. One is too expensive. Another is we don't have enough evidence. We need to do studies. So we kept getting all these GAO studies, and I would stomp around the office and say, no more studies. We don't need any more studies. Let's actually get something here. So finally, we had some legislative progress in the last 18 months, and that's actually one of the reasons we're here is to tell you about this progress, and we hope it continues. But one of the big changes was that telehealth is now going to be part of the basic benefit of Medicare Advantage. So Medicare Advantage is the private part of Medicare. It's about 20 million beneficiaries, and they receive their Medicare benefits through a health plan. And the health plans, they send in a bid to Medicare, and it gets approved. Well, up until January 1st of 2020, the telehealth portions were supplemental. So essentially, the way that telehealth was paid for was if you bid under the benchmark. So let's say it's $100 just for simplicity, and the benchmark's $100. You bid $90. That $10 delta in Medicare Advantage is what you can spend on supplemental benefits. So that's where you get your vision and your dental, your silver sneakers, and telehealth fit into that category. And it was very administratively difficult. And so Congress changed the law and put it as part of the basic benefit. This is the first time we've ever had a basic benefit in Medicare Advantage that is not also available in fee-for-service. So it was a big change. As Senator Wicker, I think maybe Congresswoman Eshoo also mentioned, you can pay for telestroke in fee-for-service Medicare, and dialysis patients can consult through telehealth at home through fee-for-service. This payment for substance abuse treatment, I just want to spend a minute on this because to me, this is the Campbell's nose under the tent. This is what's going to get us to the point where all Part B services in fee-for-service Medicare will be paid for. So as everyone knows, we have an opioid crisis, and I hate to be crass, but I like to quote Rahm Emanuel, you can't let a crisis go to waste. And we said, okay, we're going to have massive opioids legislation. What can we get in that bill related to telehealth? And so we started out with a ton of guardrails. So you can treat seniors in Medicare if the secretary says it's okay, and if the secretary gets an approval from the CMS actuary that it's going to save money. So, of course, the advocates were saying, we're really, telehealth's not going to take off if there's all these guardrails around it like that. But we said, well, this is the only way we're going to get it passed in Congress. So it passed the House. In the Senate, bless the Senate staff, because they said, well, let's keep sending this to CBO, stripping away these guardrails and seeing how much it costs, because this was all really a cost factor. So they said, okay, let's send it to CBO without this, the CMS actuary approval. And it came back, and it was still very inexpensive. So then they said, okay, well, let's just take the secretary out of the equation completely and just lift all the restrictions in Medicare for telehealth, for substance abuse, and co-occurring behavioral health conditions. So they stripped out the secretary, and then they raised it from just opioid abuse to substance abuse and behavioral health co-occurring conditions. And it came back at $11 million over 10 years, which for the telemedicine community is a huge breakthrough, because every time we were, going to members of Congress's offices, they were saying, oh, it's going to cost billions of dollars to lift the telehealth restrictions, billions of dollars. And so we were fighting against this sort of imaginary, billion-dollar price tag. And we kept saying, well, why don't we get CBO's opinion on it? But that never happened. So this enabled us to really test the CBO, poke CBO and see what they were going to think. So this payment goes into effect July 1st of next year, and you will be able to treat by telehealth Medicare patients in their homes who have substance abuse or co-occurring behavioral health issues. So we were talking last night, some of the vendors are treating patients with depression. Well, if they have co-occurring substance abuse, then you can start getting paid. And as I mentioned, there's a pretty lengthy list of codes, modifiers that are already approved for behavioral health services. So I really hope that the industry takes this up, that health systems take this up, because we're going to be going back to Congress and using this to increase coverage. And one of the strategic sort of questions is, do we go disease by disease, or do we go in and just say, lift all the restrictions and let's see what the price tag is? So that was the legislative. So after Congress passed the Medicare Advantage basic benefit, then it goes over to CMS, and CMS has to put the rules around it. So they released a rule, and it's already been finalized on sort of what the details are related to the Medicare Advantage benefit. So it passed, and oh, wait a minute. I think maybe it hasn't been finalized. No, it has been. Has it been finalized? It hasn't been. Thank you. I'm getting all my rules mixed up. See, we've had so much progress that I can't keep all the rules straight. So this is the existential win that we had in the Medicare Advantage rule. Not only was Congress saying, oh, this is going to cost billions of dollars and it's going to be, overutilization, and people are going to start, ringing up their doctors and crazily, and it's going to cost a ton of money. CMS actually acknowledged in the Medicare Advantage rule that there will be no additional increase in overall provider visits by allowing telehealth. And they said that there would be an aggregate reduction in the use of the emergency room, which has been something we've all been saying for years and have been getting a lot of resistance. So just the fact that they had this language in there is a big, big win, because CMS, the culture is changing over there, which is really valuable. And the other thing they acknowledged is the patients. They actually acknowledged that patients are going to save time and money traveling to their physicians, which is also a big deal, because that's kind of how not really in the calculation of coverage. So the other things to note, and again, the rule comments are due December 31st. So if you want to comment on any of this, you should maybe consider it. So they had a very broad definition of allowable modalities for telehealth. So store and forward, video conferencing, they allow the telephone. They looked at network adequacy, and we're going to be commenting on this because they said basically if you want to add telehealth visits, you have to have the doctor in person too. And I think it makes sense to have kind of a mix, that you always have an option to have an in-person visit, but that you can supplement those options with the telehealth provider, and especially in things like psychiatry and other areas where there's a shortage. So CMS has been very narrow in their thinking in Medicare. Medicaid's a different story, but in Medicare about network adequacy. And then these are some of the other things that we've been thinking about. Clinical appropriateness. So they have to define what's clinically appropriate for telehealth. And as I noted, in fee-for-service, you have to apply, CMS considers the code, and then they approve the modifier. In Medicare, we were very excited that they just said, we're going to treat telehealth like we do all other medical and clinical services, that the Medicare Advantage plan can decide what's clinically appropriate according to standards of care. And so that is really good news because it's an acknowledgement that telehealth is healthcare just by a different modality. They also allowed for differential cost sharing, so you could offer telehealth for free in Medicare Advantage if you wanted to, which is a big win. And then they recognized that telehealth can help coordinate benefits. This was another win because I'm sure some of you have encountered people who say, "Oh, well, if patients go get a telehealth visit, then it won't be in their record, and we won't be able to coordinate the care because there's other providers." And CMS said, we can actually increase coordination of care using telehealth. So that was Medicare Advantage. Medicare fee-for-service is the rest of the Medicare population, about 35 million people, and this is governed by the physician fee schedule. And so they finalized the physician fee schedule earlier this month, and as you heard, I think Senator Wicker was talking about, you got to hand it to CMS on this. They really thought very, very creatively about how to reimburse in Medicare fee-for-service without a statutory change. And in some ways, it does call into stark relief how important it is that we do get congressional change, because while they were able to do some things, it probably doesn't capture the value of telehealth. A lot of the value of telehealth is in follow-up care, is in treating people over telemedicine, and not having them come into the office. And some of that isn't captured by what they did, but I got to give them a lot of credit for really thinking, how do we get around the 1834M restrictions? So they are going to pay for store and forward, which is the sending of images, but you will not get paid on either side if on either side there is a visit with the patient. So I'll give you an example. If you see your dermatologist and you have like a spot, let's say, and they say, check back in with me in a few days and tell me how it's going. If you take a picture of it and send it to the dermatologist, that is not reimbursable because it's attached to a visit. But if you had a spot and you said to your dermatologist, you took a picture and sent it to the dermatologist, and they said, oh, that's nothing to worry about, that is reimbursable because there's no visit on either side. So they were very careful to wrap it. If it's wrapped in with a visit, you don't get paid separately for it. The interprofessional consultations, in years past, basically, if you are a physician, and for those physicians in the room, I'm sure you've probably had this experience where you call a friend or a specialist that you've worked with in the past for a second opinion. Will you evaluate this patient? You don't get paid for that. The consulting physician does not get paid for that. CMS is now going to start paying for these services, which really makes a lot of sense, right? Because if you're asking the opinion of an expert who spent a long time training to be an expert, they should get paid for their expertise. One thing that is difficult that we may try to advocate to change is that you can't really combine store and forward and the interprofessional consultations. It would be nice to say, hey, I'm sending you over all the images. Can you look at all these images and get paid for the transmission of the store and forward and the consultation? But the store and forward language says that the patient has to transmit. So the patient would have to send the imaging. The sort of the big headline out of the physician fee schedule was the virtual check-ins. And basically, it's 5 to 10 minutes that you speak with your provider. It can be by phone or video. It's a very broad definition of how these check-ins happen. Once again, they cannot be connected to a visit. So I really understand this to be triage, I think. And we asked CMS to clarify, can you actually treat someone in this 5 to 10 minutes and get paid, or is it really triage? And you can treat someone, but you can't do any follow-up, or it would trigger an E&M code visit, which then means you don't get paid for the telehealth visit. So I think I've got the amounts here. Yeah. So the code for the brief visit's $15. So for 5 to 10 minutes, you get paid $15. And in some cases, in many cases, I think, physicians are doing this already for free. But you're still giving professional advice that you've worked a long time to get. So it does make sense that you would get paid for that advice. And then the store and forward is $12, and then there's quite a bit of difference on the interprofessional consultations. Depends on how long you spend with the patient. So it can be anywhere from $18 to $72. Excuse me, not how much time you spend with the patient, but how much time you spend consulting on that patient with your colleague. I told you this was going to be a lot, so hopefully you'll still remember all your questions when we take questions, because I think Administrator Verma is going to be here shortly. Okay, Medicaid. So last Friday, the Medicaid managed care rule got issued, and I mean it's like diametrically opposed to what they did in the Medicare Advantage rule. So Medicaid managed care is just like Medicare Advantage, except in the Medicaid program. It is Medicaid administered by private plans. And what they said is, we don't think there should be a federal standard on network adequacy, time and distance. So right now in Medicaid, you have time and distance standards for in-person care. So you have to, as a Medicaid managed care plan, ensure that there are enough providers in an area that your patients can go see a doctor within, say 5 miles, depends on the area. And basically what they did in the Medicaid managed care rule is propose that that states come up with their own time and distance standards, and they have a lot of flexibility. And so this opens up telehealth in Medicaid significantly, because you can now fill in the network for Medicaid beneficiaries. And for any of you in the room who have worked in Medicaid or Medicaid policy, you know that the payment rates in Medicaid are generally very low. And so it can be difficult to get providers to take Medicaid patients. And so in this case, this will open up, and this is a proposed rule, it's not final yet, so if anyone wants to comment, this could open up Medicaid to telehealth. Maybe I am coming towards the end, let's see. Okay, this is more on the Substance Abuse Disorder Act that I was telling you about. This is the opioids bill. It's officially called the Support for Patients and Communities Act. And they actually have already issued rules on this. And as I mentioned, it'll go into effect July 1st of next year. And so I'll talk a little bit about broadband developments, and then if we have time, I'll talk about what's coming up in 2019. So more and more, are we ready? Okay. I'm getting the hook. I'm hooking myself. I'm going to go ahead and introduce Seema Verma, the CMS administrator, once I see her. It's kind of nice when you can just hook yourself. Don't have to give any signals or, I know you're all going to be waiting on the edge of your seats for the broadband developments that we're going to talk about later today. Let's see. Okay, well, I want to make sure I see her, so. Well, breaks, we're going to have a little break here for a second while we wait. Well, I'm going to tell you, just while we're waiting here, I didn't appreciate the broadband problems that we have related to telehealth, probably because I live in Arlington, Virginia, where there's plentiful broadband. And And I've realized over the last 2 years how important the broadband aspect of this is. And there's really two aspects to it. One is more broadband in rural areas, but also people in urban areas that can't afford the data packages. So it's really two parts. And Allie Logston here, who is with the Veterans Administration, has been working on this issue because the VA has one of the best telehealth systems in the country, and yet there are many, many veterans living in rural areas that that can't access broadband, and so therefore it sort of becomes a moot point. And telehealth is a huge use case for broadband, and I expect that there's going to be a lot more work on it. And honestly, what the VA does will like create a best practice for all of us on broadband. So thanks for being here today, Allie. And now I'm getting the hook. Ready? Our next guest I'm honored to introduce is CMS Administrator Seema Verma. She has been a staunch champion of telehealth and remote patient monitoring reform since she joined the administration in 2017. And I'll say my first meeting with her, she said, telehealth is on my whiteboard. It's really big on my whiteboard, and my staff know that it's a priority for me. And that was a great relief to us because we had been advocating for years beforehand and not getting anywhere. And I think as most of you have advocated on telehealth in the past, know that sometimes it falls lower on the priority list in these programs. So under her leadership, CMS has rolled out landmark changes in telehealth and remote monitoring. And I was just spending the last 45 minutes telling them all about it. And in fact, I got my rules a little confused because there's so many that have actually come out since you started as administrator. So we are just so honored to have her. And again, her leadership has changed the landscape on these important tools. So thank you. I'll welcome her to the stage.
Well, good morning. It's a good day for telehealth, right? The weather's bad and you need to get a visit to the doctor. It probably would be easier to do it remotely. But thank you, Krista, for that kind introduction and all of you for joining us today. And it's a privilege to be here with the Alliance for Connected Care. And I'm glad I got to meet with your organization early on in my tenure. And as Krista said, it was a priority. I asked our team across CMS to essentially figure out how we can deliver on telehealth and bring this benefit more widely to our Medicare and Medicaid beneficiaries. And I'm particularly happy to continue our conversation on how we can make the promise of connected, coordinated care a reality by building on a foundation of innovation. So at CMS, we've been working to lay that foundation, including through supporting innovation in healthcare on many levels. And so I look at telehealth as sort of part of that overall vision on innovation. And it's part of our larger vision of moving to a system that is value-based, that rewards value over volume by bringing the best to our patients. And when we start paying for value, we will foster innovation as providers look for ways to compete for patients by providing the highest quality care at the lowest cost. And we understand that relentless innovation is a crucial driver in creating value across all industries. And as Thomas Edison noted, there's always a better way to do it. Find it. And healthcare, of course, is no exception. So over the past several decades, thanks to improved diagnostic and therapeutic treatments and tools, healthcare has witnessed a myriad of innovations that have brought value, extended our lives, improved them, and created efficiencies in the entire healthcare system. And healthcare innovation is, in fact, serving as a catalyst to improving quality of care, enhancing access to care, increasing efficiency in the system, and lowering healthcare costs. And take the history for knee replacement surgery, for example. Not long ago, knee replacement surgery always required a multi-day hospital stay and then a lengthy, often painful rehab. But today, the patient experience today is entirely different. Innovations in anesthesia have allowed total knee replacement to become outpatient surgery for some patients. And replacement knees, custom designed through 3D scanning and printing processes, are allowing patients to walk shortly after waking up from surgery, which speeds the recovery and reduces pain. And doctors can now use a 3D model of a knee taken by a CAT scan to guide a robotic arm during surgery and spare as much of the patient's healthy bone and surrounding tissue as possible. And we're also now seeing the same kind of benefits as more surgeries, including full knee replacements, are being moved to the outpatient setting. And some surgeries that used to require hospital care can now safely be done in ambulatory surgery centers. Innovations in the procedures itself resulted in better patient outcomes and the ability to provide care in a lower cost and more convenient setting. And this is a prime example of how leaning in to technology can better health outcomes, lower costs, and drive efficiencies. And while some technology is very specific to healthcare, some of it is not, such as our smartphones, but healthcare is taking advantage of that as well. And innovation is also giving patients more choices and improving their overall quality of life. So I traveled to California last year, and I got to take a ride in one of those driverless cars. And with driverless technology, older adults could continue to live in their homes late into life. So, people ask me, well, why did you go and, why did you take the time to do this? And I wanted to get a sense of this because as we're serving older individuals, disabled individuals, that technology that wasn't designed for them specifically could be applied. And so, for example, in Japan, rural communities are populated by an increasingly older set of residents as younger Japanese citizens are moving to cities. And this is leading to a shortage of transportation workers. But the driverless technology is slated to eventually address this problem and allowing seniors to remain in their homes and communities using the cars to deliver meals and helping these seniors get to their doctor's appointments. And as you well know, technology is also connecting patients to their doctors even outside of the hospital setting with devices like new glucose monitors, which we just approved, that can continually monitor vital signs and relay them to a practitioner. And recently I also got to visit the Cleveland Clinic, and I saw firsthand some of the innovative ways that they're using remote patient monitoring from a central hospital command center. And their model uses a mission control operation where off-site personnel use sensors and high-definition cameras to monitor patients and assimilate data to trigger on-site intervention. And the Cleveland Clinic is also sending paramedics to seniors' homes and connecting them virtually to doctors, which means that doctors can see more patients in less time. And this approach can dramatically increase efficiency as well as improving clinical outcomes. Additionally, when remote patient monitoring systems can send live-time data back to clinicians, adjustments to medication can be made for patients with hypertension or diabetes as soon as it's clear that these chronic conditions aren't being controlled through a patient's prescribed regimen. And wearable technology is also providing new data streams. Patients can wear a watch that tracks their heart rate and can identify irregular heart rhythms, and may also be able to perform an EKG. And doctors get insight into what's going on with their patients outside the exam room. And this is truly a whole new world of healthcare innovation. Technological innovations in healthcare have impacted me at a very personal level. I've told many people about a story of my husband who had a near-death experience last year. And thanks to the bystanders and the medical team that treated him, he was able to survive a very serious cardiac episode. But even before he got to the hospital, he was at the airport, there was a defibrillator there. And that defibrillator, which they had to use 6 times, brought him time to get him the great care that he received. And it's just another great example of how technological innovation is saving lives. But taking it a step further, as I kind of looked back on what happened to him, maybe we could have predicted his cardiac arrest before it happened if his electronic watch or some other novel device had been compiling information about his activities, his heart rate, his breathing, as well as other data, and sending it to his doctor. And ultimately, that's an illustration of both the current power and the future promise of innovation in healthcare. Undoubtedly, innovation is the fuel that powers the engine of progress and creativity. And while we're on track for healthcare costs to represent 1 out of every $5 of the American GDP by 2026, it's technology that I think will help ensure the sustainability of our healthcare system. And that's why at CMS we're trying to lean into innovation. Fostering innovation is a priority for me. And one of our examples is our focus on interoperability through our My Healthy Data initiative. The My Healthy Data initiative is something that we're working on with Jared Kushner out of the White House Office of Innovation. And that essentially takes a very comprehensive approach to ensuring that patients are controlling their health information throughout their entire healthcare journey. And we're committed to moving interoperability forward. Because the reality is that once information is freely flowing from the patient to the provider and follows them throughout their entire healthcare journey, it will help to spur innovation in the entire system. This is the beginning of the digital health revolution. And advances in coordinated, value-based, and patient-centric care will be even greater than anything that we can imagine today. So imagine if patients could authorize access to their records to researchers from all over the country who would not only develop specific treatments for their needs, but the researchers could also use that information to develop cures that could save millions of lives, like what NIH and the ONC are doing with their Sync for Science program. And in order to achieve this, machine interoperability must also be addressed. Earlier this year, I had the privilege of visiting the Center for Medical Interoperability in Nashville, and I heard about doctors still having to put EKG results into the patient's EHR. So we have to get the electronic health record to also connect to the medical devices, and they all need to be able to connect seamlessly. We're committed, and I'm personally committed, to removing any and all bureaucratic and legal obstacles to machine device and EHR system interoperability. And to this end, CMS has already taken a lot of action. We have overhauled what was the Meaningful Use program in order to focus on promoting interoperability. And so we renamed it that. There's no more meaningful use. There's just promoting interoperability. And we've stated that hospitals that don't give their patients their data within the next 2 years will be penalized. And through the MIPS program, incentives for physicians will be tied to interoperability as well. So both of these changes will push the system towards interoperability. We're not done. There's going to be more coming, so stay tuned. But we did this because interoperability will spur the next generation of innovation. And through My Healthy Data, CMS has also essentially launched a data revolution that is sweeping the healthcare market and changing the way that we think about healthcare data and information. And we're liberating data that will drive innovation throughout the entire healthcare system and create new tools and solutions that will allow the system to deliver better value to patients. And of course, we're also looking especially to promote innovation by supporting and furthering telehealth, which is changing the very face of healthcare. And we know that guided by what is best for patients, telehealth innovations could help usher in a new world of healthcare that is embraced by both patients and providers and that identifies new avenues of care delivery that improves the value of care and increases quality and also lowering cost. For example, for stroke patients, response time is critical as life-saving clot-dissolving treatment can only be administered within 60 minutes of the onset of stroke symptoms. And a study done by Kaiser Permanente found that telestroke programs led to a 73% improvement in the rate of administration of this life-saving treatment among stroke patients at places where there was limited resources or limited access to neurological expertise. And telehealth also gives patients choices. It gives patients another way to access care and puts them in the driver's seat as they seek new options. And it's particularly vital for our elderly and disabled populations as well as their caregivers, where we know that transportation issues can be a barrier to care. Telehealth also enables patients to become active members of the care continuum outside of a hospital setting and promotes long-term engagement between patients and practitioners. Using technology, a patient managing a chronic condition can connect more frequently with their care teams from home and spend less time going to the doctor's office. And telehealth has especially provided a lifeline in rural areas that are characterized by great distances and a limited number of healthcare providers and specialty services. But with a growing aging population, rural healthcare cannot rely simply on traditional brick and mortar practices. Technology can also reduce costs by lowering readmission rates, as well as unnecessary hospital visits through better care coordination. And that's why, as part of our rural health strategy, advancing telehealth and telemedicine was identified as one of our 5 primary objectives. But, and I've said this before, I don't think telehealth is just a rural health issue anymore. Anyone that's faced DC traffic understands that people living in cities could benefit from virtual access to care. And as you may be aware, Congress authorized Medicare's telehealth benefit in 1997, and the benefit began in 2001. Well, there's obviously been lots of updates since then. But the law still means that Medicare can't pay for telehealth when patients are in urban areas and can't pay unless the patient goes into a healthcare facility in order to connect to a distant doctor remotely. And Medicare patients still can't usually get telehealth from their homes. And that probably wasn't considered necessary when the law was created because internet connections were far slower and video chats were not as commonplace as they are today. But as we are going to see 20 million people coming into the Medicare program, we understand at CMS that we need to embrace the promise of technology and innovation in order to be able to serve beneficiaries. Unfortunately, Medicare's rules and governing statutes are often a barrier to innovation, and which is why I always say I have very significant issues with the Medicare for All proposals. We too often see that new products and new technology just don't fit into our existing payment system, which is set up by law. And now sometimes, we can figure out ways to shoehorn new devices into the Medicare benefit design. And recently, the Trump administration did this when we clarified policy to ensure that Medicare beneficiaries with diabetes could use apps on their phones to get readings and data from continuous glucose monitors. But again, this wasn't easy. It took years. And meanwhile, patients went without new technology that could improve their health. Many diabetics had this technology with their private coverage before they came to Medicare, but when they came to Medicare, they lost access to these devices. So historically, telehealth has been used to connect patients who are in one provider setting to a specialist located at a distant site. But technology is quickly moving beyond that, and CMS and Congress have to keep up. And there's no reason today that seniors shouldn't be able to use their smartphones to connect to their doctors, especially because it's what patients want and it's what they need, and it means that we are leveraging today's technology and innovation. More and more of our Medicare beneficiaries are using technology in every aspect of their lives. And so one of the things that we've done is launch our e-Medicare program. And that's essentially preparing for this new generation of seniors that are coming into the program and recognizing that this is a generation that's used to using computers, and they're going to expect the same type of innovation that they get in their private programs in the Medicare program. So we're doing things like updating our tools. We have a new Medicare app. And what you're going to see over the next year is a lot of new things that we'll be launching to help our beneficiaries leverage technology. And recently I met with the Alliance of Community Health Plans, where we discussed a number of ways that telehealth is being successfully deployed: wound care, mental health counseling, questions and challenges related to medication adherence, lifestyle coaching. These are all areas in which telehealth is being used to improve care for patients and helping providers deliver value to their patients. And this is especially true as we look to address the social determinants of health. This is where technology can help deliver on those types of services as well. And whether it's doctor-to-doctor consultations that prevent unnecessary referrals, or consultation centers that give local communities access to dozens of specialties from a single location, technology offers solutions. And that's why this administration has taken action. I think Krista probably did a great job of running through what we've done, but I'll go through my laundry list again, because we want to make sure that people across the country can take advantage of telehealth, not just those in rural settings. And so every year we're adding new services to the list of what can be covered by Medicare via telehealth. And this year that includes prolonged preventative services, which includes wellness exams for patients with complex needs. But we didn't stop there. We're committed to taking bold steps to foster innovation in this area. And I'm proud of the very historic steps that we've taken for the program. For the very first time, starting in January, Medicare will pay for virtual check-ins, meaning patients can connect with their doctors by phone or video chat. And as all of you know, many times a virtual check-in will resolve a patient concerns in a convenient manner that gets them to the care that they need and avoids unnecessary costs for the system. This is an incredible step in the right direction for our beneficiaries. And for the very first time, we will also be paying for virtual consultations between physicians and evaluation of remote pre-recorded images and video. So for example, a patient could now text a picture of a mole on their skin to a dermatologist for examination. And additionally, our recently released home health rule will enhance the ability of home health agencies to use remote patient monitoring for their Medicare patients. This will allow patients to share more lifetime data with their providers and caregivers. And ultimately, this will lead to more tailored care and improved health outcomes. And also new for 2019, under our final rules, Medicare patients receiving home dialysis will be able to receive their monthly clinical assessments via telehealth from their homes. And patients experiencing symptoms of an acute stroke will be able to receive telehealth services from mobile stroke units. And finally, we've also proposed options for modernizing and expanding telehealth through our CMMI models and demonstrations. So when providers take accountability for healthcare costs, we want to give them more flexibility to innovate so they don't have to keep coming to CMS for permission to test a new approach or some type of innovation for care delivery. And we're particularly focused on using our waiver authority to spur innovation in the telehealth space. So these are all exciting changes which will increase access to care, give patients new choices, and foster the types of innovations that we need to strengthen and ensure the sustainability of the Medicare program into the future. And we know that given Medicare's size, that whatever we do affects the entire healthcare market. And we also know that even bolder innovations are emerging in the private sector. Private plans report very high patient satisfaction with virtual care, and it's no surprise that patients like faster and more convenient access to care, which more and more seniors are using. Health plans are using telehealth to support patients in areas like medication management, so patients can get guidance from clinicians after they leave the pharmacy counter. And patients are using video chats to learn how to use their medical devices, even for complex cases like home dialysis. And we're very excited for plans to have greater flexibility to bring this type of benefit through the Medicare Advantage program. So we just released a proposed rule a few weeks ago, and in 2020, Medicare Advantage enrollees will have more options for receiving telehealth services beyond what is otherwise available in the traditional Medicare program. Because again, we want to increase flexibility for entities like Medicare Advantage plans that take accountability for total healthcare cost. The proposed changes for Medicare Advantage are a major step towards expanding access to telehealth services, because the rule would eliminate barriers for private Medicare Advantage plans to cover additional telehealth benefits for enrollees in MA plans. So ultimately, whatever CMS is doing to promote telehealth, it's really about one thing: to foster innovation and protect and strengthen the Medicare program in order to deliver on its promise to our elderly and disabled populations. And of course, we can't accomplish this alone. This important work affects all of us, our families, our friends, and our future. And my challenge and charge and call to action today is for all of you to be our partners in this important work. We need your ideas and input, and we need the benefit of your expertise and experience. We need to hear from you and work with you. Innovation proves that in healthcare or in any other industry, there's always a better way to do things. And so let's find that together. It's been a pleasure to be here with you today, and I wish you a very successful forum that will help foster and promote not just telehealth, but innovation throughout the entire healthcare system. Thank you very much.
Okay, we're going to break until 10:45, and then we have 2 sessions before lunch. We're going to hear from Will Brady, who's the Associate Deputy Secretary of HHS, and then we're going to have a case study from Chris O'Dell on implementation in academic health systems. So please enjoy some refreshments during the break. Good morning. We're going to get started. So for those of you who did not get coffee, we have another urn of it delivered at 11 o'clock. So sorry about that. So it is my privilege and honor to introduce Will Brady. He's the Associate Deputy Secretary at the Department of Health and Human Services. He coordinates closely with the Deputy Secretary to develop a policy vision that encourages consumer-driven healthcare and allows patients to be able to fully leverage their own data, health records, to make their own healthcare decisions. Will and his team have created a culture of forward-thinking, tech-focused policymaking at the department that resonates and sets the tone for agencies like CMS, FDA, SAMHSA, and more. For those of you who are not from DC, I apologize for all of the acronyms today, but I'm assuming you've heard of the FDA, and SAMHSA is the Substance Abuse and Mental Health Administration. Based on recent developments that have come down from HHS during Will's tenure, we're excited to hear from him, and so please please join me in welcoming Will Brady.
Thank you for that kind introduction, and thanks for having me here today. And as Krista said, for those of you who don't know me, my name is Will Brady, and I'm an Associate Deputy Secretary at HHS. That was probably one of the best explanations of what we do, but when I tell people that, I've learned it doesn't provide a lot of clarity of anything about me or what actually that role entails. So I'll try to provide a little bit of color, but as she mentioned, I report to the Deputy Secretary, and my primary areas of responsibility include CMS, FDA, the Chief Technology Office, administration, and budget. And prior to HHS, I was in-house counsel at a large health insurer. And before that, I founded a software company that did mobile ordering and fundraising. So I hope that provides a little bit about my background. But once again, as I've spoken a little bit, people say, okay, well, what do you actually do as an Associate Deputy Secretary, and what's the Deputy Secretary's office do? And so, by reg or statute, the Deputy Secretary is the Chief Operating and Chief Regulatory Officer of HHS. We're a key part of driving policy and strategy at HHS, but I'd say what's unique about the Deputy Secretary's office is we're also looked to for performance of the strategy, and we now have a particular focus on driving innovation. And so that's a couple of things that make us unique. But as Chief Operating and Regulatory Officer, as I said, we're responsible for making sure the department forms on its strategic vision and agenda, like value-based care, combating the opioid epidemic, lowering drug prices, and reforming health insurance. And what this means is we make sure that regulations and guidance are issued timely with policy alignment. We build the right teams to drive initiatives. We lead budget development and creating a customer service culture, and all the things that are necessary to make sure a large organization is operating smoothly and successfully. As I mentioned, in addition to performance, the Deputy Secretary's office has a particular focus on driving innovation. Now, we know innovation is one of the buzzwords of our time, and everybody wants to be a part of it. But when we talk about innovation, we mean thinking of and adopting new ways of doing things better to succeed in our mission. And that's really how we look at it. And I think it's important to mention that innovation isn't just an app or technology. It includes things like creating new culture, novel business models, altering behavior, and all the things I think we know that are necessary to change how organizations run. We strive to innovate within government, but also, and more importantly, we strive to drive innovation within healthcare. I think we all know that moving healthcare to a value-based and consumer-driven industry will require a lot of innovation. Within government, we push innovation in ways like reimagining how we purchase goods and services by leveraging things like distributed ledger technology to allow us to better share information and that facilitates better purchasing decisions. Or by reforming HHS's culture and realigning it to one that pushes the mindset that no matter where you are in the organization, you have customers. Whether you're an internal service provider, whether you're serving Medicare beneficiaries, you have customers, and your focus needs to be on how to better serve that customer. Now, when we talk about facilitating innovation in the healthcare industry, it's a little different than driving innovation in government. And we know innovation is critical within the healthcare sector to better deliver outcomes at lower costs. But the government doesn't actually build or implement these innovative healthcare solutions. That's the private sector. The government, acting as a regulator, a payer, and an oversight entity in its many functions, really helps create frameworks or environments that facilitate or hinder innovation. And we've thought about a lot how we can accelerate innovation, knowing what our roles and abilities are, and we focus our efforts in three major ways. The first, leading, convening, and facilitating. We lead by trying to communicate a strategic vision of where we're driving the future of healthcare. We try to convene by bringing people together to discuss the important topics to move to that vision and build partnerships. And we facilitate by developing policies that appreciate and encourage innovation as opposed to those that create are a barrier. So I share this with you to provide a little bit more about the Deputy Secretary's office, but more so to provide some insight on what drives our thinking and how we've come to think about telehealth in its future. Now, coming from an office that's focused on performance and innovation, I'm excited to be here speaking to a group focused on telehealth, a healthcare innovation that's ripe for expansion, that has a lot of opportunity to improve performance within the industry. We're highly optimistic about telehealth in both short and long-term benefits and the impacts it'll have on the industry. But before getting to that, I do think telehealth, like innovation, is somewhat of a buzzword like value-based care, and it's important to just do some table setting and define how we think telehealth. In our view of telehealth and the definition is similar. It is a little bit less restrictive than we've seen in regs or statute or certain capabilities. But when talking about telehealth, I'm referring to the broad definition of providing healthcare, patient guidance, data sharing remotely through telecommunications technologies. And so in the near term, as I said, we, like many others, see telehealth having the ability to increase access and reduce cost. We've already seen the benefits of access to this firsthand in Alaska. In remote villages of Alaska, where doctors are literally a plane ride away, telehealth is used in the community through community health centers to connect individuals with providers. I was recently there in September and saw it firsthand. An individual connects through telehealth, and in Alaska they don't have broadband, they don't have Wi-Fi, they have something called microwave connectivity, which is an interesting thing in itself, but they've still managed to provide telehealth to where a patient can see a physician in Fairbanks who's really 200 miles away. This combined with a medical vending machine is probably the best way to put it, allows patients to see a doctor and receive a prescription on-site in a remote village of 100 people. And I think that's one of the things that we've seen telehealth already have great benefits for. And we know the costs and the negative health outcomes that could occur if an individual doesn't see a doctor, doesn't get the medication, and the condition escalates to where you need an emergency evacuation from a remote village in Alaska. Now, this may seem like an extreme example, but we know this model has also produced benefits in rural areas that aren't part of the last great American wilderness. Not everybody has to, get on a plane to fly to see a doctor. But I will say that this hits close to home for the Deputy Secretary, literally. He's from Mounds, Illinois, the most southern tip of Illinois, if you're familiar with the state. From a very rural community that we don't really know if they have electricity or not. He won't give us a straight answer, but it's a community that's fairly isolated. But the small community of Mounds has limited access to hospitals. The hospital he was able to access has since closed since he was there, and even more so to specialists. And he's even seen firsthand in that environment how telehealth has provided access to these specialists that doesn't require an individual to travel 200 miles for them to take a day off work. And in many cases, we know those barriers can prevent people from getting the treatment they need that cause conditions to exacerbate and reduce health outcomes and increase costs. So as I mentioned, to accelerate innovation and specifically telehealth, we've worked to facilitate a framework that supports innovation by evolving reimbursement frameworks and removing barriers. So I'm sure you heard from the administrator earlier, we're pleased to expand access to new telehealth capabilities by providing reimbursement for types of virtual visits, remote patient monitoring, evaluation of pre-recorded information, and interpersonal consultations. All of these developments advance the use of telehealth to provide patients with greater access, lower costs, and keep patients engaged in their healthcare outside of the on-site interaction that they're so used to. Now, reimbursement is no doubt a critical aspect to expanding access to telehealth and realizing those near-term benefits, but it requires more than just reimbursement. Telehealth is an innovation, and innovation requires adoption. This includes adoption by health systems, adoption by providers, payers, administrators, and patients. Telehealth includes new tech, software, training, and a host of other elements that are necessary to get this diverse stakeholder group to adopt. It also requires these stakeholders to reconsider how they operate together in a new way. This is no easy task, and just putting a reimbursement isn't going to magically fix and accomplish all these elements that need to be fulfilled. So we know the adoption chain is incredibly complex, the stakeholders are diverse, and the regulatory scheme only makes this more challenging. Now, as I mentioned, certain regulatory frameworks have not always been friendly to diverse stakeholder adoption, and in some ways are flat-out barriers. The Deputy Secretary is all too familiar with these regulatory barriers from his private sector experience, and to address these, he launched the Regulatory Sprint to Coordinated Care. Some of you may have heard of it, and I think some of your organizations have actually been involved. But the goal of the Regulatory Sprint was to specifically focus on 4 regulations that we know have had, been acted as barriers to innovation in things like telehealth. Those are the Stark Law, the physician self-referral law, the anti-kickback statute, 42 CFR Part 2, and HIPAA. Now, these regulations all have good intentions, but they haven't always adapted to industry and technology in a way that's allowing for the use of these new innovative services. So we're reviewing these regulations with a couple questions in mind. The first is, how does it affect patient engagement and a patient's ability to understand treatment plans and make empowered decisions? How does it affect providers and their ability to align on end-to-end treatment approaches? How does this incentivize providers to coordinate, collaborate, and provide patients or other providers that they work with tools to be better connected? Another one is, how does this support or hinder the movement to value-based care, healthcare arrangements, and how does it help information sharing and create better connectivity? Now, these regulations should incentivize the provision of better health outcomes at lower costs by encouraging innovation and the adoption of these new technologies. So, one of the things we always try to help with when we're speaking out is, so how can you help and how can you get involved? So at HHS, we hear from a lot of people often, and this is helpful, but it's government and formal processes are how things are done. But I strongly encourage all of you to get engaged in the regulatory process if you haven't. As I mentioned specifically, the Stark Law and anti-kickback statute RFIs that we've put out have closed, but as NPR notice of proposed rulemaking come out, we encourage you to engage and help us reform these laws to allow for the adoption of these new technologies that produce better outcomes and lower costs. And I also encourage you to stay tuned on HIPAA developments in HIPAA and 42 CFR Part 2. But we know this effort isn't a silver bullet, but it is a really good opportunity to remove some of the barriers that stifle innovation and creativity, whether that be through technology, provider business models, and coordination. And we need your input to make the most of this. So once again, that's a really strong emphasis on encouraging you all to stay engaged and connected in this effort. Now, these near-term advances will no doubt have significant impact on expanding specific types of telehealth that I mentioned, but what we're really excited about is the long-term impacts of telehealth. As you've heard time and again, I'm sure, one of HHS's goals is transforming healthcare into a system that is value-based and consumer-driven. This will require significant innovation in healthcare culture, practices, and technology adopted, as I mentioned, by a diverse set of stakeholders. The most important of this group of stakeholders, we believe, is obviously the consumers and the patients themselves. A consumer-driven economy requires consumers to feel confident in their ability to drive their healthcare and demand value. And at this point, I think we've all seen that consumers don't feel like they have that knowledge, ability, or connectivity to drive their healthcare and aren't confident making healthcare decisions outside of, in most cases, these on-site interactions. This puts a lot of strain on patients, doctors, and the system in general, that you're only allowed to influence in those short windows. To really transform the healthcare system, we need consumers to be confident in their ability to manage their health outside of these traditional sites of service. This barrier of consumer culture actually became most recently obvious to me in a conversation with my wife. So we have a son who's almost 2. And when he was about 11 months, he either had 10 ear infections over 4 months or a 4-month-long ear infection. It wasn't clear to us, but for those of you with kids, you may be able to relate. So we're up at 2 in the morning and trying to figure out what to do, and he's got a fever. And so, it'd just be great if we could telehealth into a doc. Our doc isn't awake, it's 2 in the morning. Explain kind of the situation, the background, have the doctor give us guidance. We either go get a prescription or we know what to do. Now, my wife looked at me like I was crazy. Health in the future falls into one of the initiatives in the Deputy Secretary's office that we refer to as PETS. So you heard, in government, you never miss an opportunity to create a new acronym. So that's what we've done with PETS, in that we use the term to refer to patient empowering technologies. So we consider PETS a combination of capabilities working together: virtual connectivity, remote monitoring, data sharing, proprietary devices, and as I mentioned, telehealth in general, being able to provide patients with the right information at the right time through the right channel to give patients the confidence and the actual ability to manage their health outside of these traditional settings, and to also be able to connect with providers when they need to know if they need to move to a different site of care, a different modality of care. And we know this can significantly lower costs and improve health outcomes. This will also, I think what's really important is allow providers and systems to better manage and treat their patients, having better data and information into what's going on outside of their direct interaction with the patient, and allowing providers to better use their time to focus on the patients with the most critical need. So to get to this future, we need to take steps both technologically and culturally to get people to adopt these technologies and be confident in these new types of delivery. We've seen development in tools allowing consumers more power in managing their healthcare expenses, like HSAs and FSAs. And now we need to take the next step to actually giving consumers the tools to manage their health and health care, not just how they spend their financial resources. They need to be able to do that wherever they are. Things like telehealth and those innovations are going to be critically important to moving consumers to that direction. And as I said, we think telehealth is actually one of the key channels that will help consumers develop this confidence that they will have the right information and connectivity to make good decisions outside of traditional interactions. And what's important is this confidence won't be misguided because they actually will have the connectivity. I mean, we've already seen it, as I mentioned in the example from Alaska. They'll have the connectivity, they'll have the information and the collaboration to make the right decisions or move to the right side of care. This means consumers will be more frequently engaged. They'll receive the care they trust without having to travel 100 miles, without going to the wrong site, without really knowing who they need to go to when, or what they need to do in a certain event. And we truly believe this confidence and ability will help consumers drive their care and demand the value they want from their care. Now, I'd say in this example, I don't remember when I downloaded the Uber app and asked a stranger to drive me somewhere and pay them money and get in their car. And I think that's a good indication of consumer confidence. And I think a lot of us are like that in these new ways that we live and do business. I think we're all looking for and hoping for the day when consumers don't remember when they first interacted with a provider or made a healthcare decision through things like telehealth or PETS. Because it would have been crazy to think that that's not an appropriate channel with which we manage our healthcare. So once again, and to kind of close, it's so how can you help, and what's the key takeaway? One critical takeaway that I always emphasize, as I touched upon earlier, is a stress to engage. As hard as it can be with the government to engage, I can't stress it enough. And I can speak personally and for HHS that we have a big appetite for creative thinking and innovation, because we're of the belief that we're all partners in this with a goal of improving the health and well-being of American people. So I'd really encourage engagement. But the first way to do it is, as I mentioned, through the formal process, which is critically important to make sure that things are being done appropriately and through the process, but also through other channels as well. As I mentioned, kind of the PETS initiative is a way to kind of reach out to our office and give us a little more insight into how you guys are thinking about your vision for the future of telehealth. We've also launched what we call the Deputy Secretary's Innovation and Investment Summit, to where we're bringing together a diverse set of individuals across the healthcare sectors and investment innovation life cycles to address the things that are going to be forthcoming, to make sure that we're not behind in things like telehealth and the future innovations that are developed in the industry. Now, when engaging, I would also stress it's important to remember that the technical comments and information is helpful, but it's also very important to provide the practical implications and the stories of how these changes will actually affect patients and drive new business models and creative thinking. And lastly, with the direction or guidance I give is to focus on consumers' and patients' needs, to have the ability to better engage and drive their health care. As I said, they're the most critical piece in moving to a consumer-driven and value-based healthcare system. And we're just at the beginning of providing them the tools they need and the connectivity that they want that'll give them the ability to manage their health and healthcare. And so we look forward to working with all of you to drive innovation like telehealth in ways that create a value-based and consumer-driven healthcare industry that will provide better outcomes and lower costs for everyone. So with that, I once again thank you all for letting us come here and share our vision and provide hopefully some ways you can engage, and thanks again.
Okay, so we're going to hear from Chris O'Dell from Stanford, and then we're going to break to get some lunch. Chris is the Director of Digital Health Strategy and Alliances at Stanford. He identifies and enables digital health programs and initiatives that align to the broader Stanford medicine strategy. His team has a particular focus on digital health solutions that improve access, leverage limited physician resources, and reduce physician burnout. Before coming to Stanford, Chris served as the manager of revenue cycle at Lucile Packard's Children's Hospital and was a senior associate at Triage Consulting Group. He has a BA from UCLA and completed Stanford University's Graduate School of Business Executive Education Lead Program. Thanks, Chris.
Thank you very much. So I'm the speaker that's between you and lunch, but Krista said that there's a vat of coffee out there, so hopefully we won't need too much of that. But I'll quickly clarify. My name's Chris O'Dell, Director of Digital Healthcare Integrations, which is a team that we've organized at Stanford, specifically angled to deliver that last mile of getting telehealth into the actual operations. I think it's a good analogy today, given that we're talking a lot about broadband, and so you think about the success of AT&T, is not laying those large broadband, which are the guardrails of cable going out. It's getting it to the actual individual houses, and in our example, that's the patients and providers that want to use this stuff. Little bit about Stanford. We are an academic medical center based in Palo Alto, which is in Silicon Valley. We have an adult hospital, which is where I work, and a children's hospital, school of medicine, a couple regional facilities, a network of care, physician practices, and we do about 1.2 million outpatient visits a year. We're most recognized for some of the programs that you see down here on the lower right, including cancer care, cardiology, transplant. So today I want to talk a little bit about some of the actual programs where we're applying telehealth. I think that these are really innovative programs, but probably not unique to Stanford, and that I think a lot of the other health systems out here, I know a lot of the other health systems out here are doing similar programs. And my goal here is to show that telehealth is not always just telehealth, that it's not always just non-demand application of it. There's a lot of different ways and modalities that we can use this. I'll talk about some of the barriers to adoption as to why we haven't seen such broad uptake of these in different health systems. Talk a little bit about how I think some of the proposed legislation that Chris has done a good job outlining is going to impact healthcare systems, and then some of the future state opportunities that we can take as health systems to make sure that these programs are being heard. So I'll kick off here first by talking about a program that we call PhotoCare MD. So this is a asynchronous dermatology consult program. And it is actually a really good application as I'm going through this to think about the interprofessional consult model that we're talking about. So in this example, the PCP, primary care physician, captures a photo of the patient's skin condition right in the office. It's deeply integrated into Epic, which is one of the main things that we were testing when we launched this, is rather than bolting on a separate teledermatology offering, can we build this into Epic so that the dermatology condition that's being looked into is part of your primary care, part of this specialist. The documents and notes are sent along with the consult back to the dermatologist, and within 24 hours, the dermatologist picks up that message, reviews it, and renders a diagnosis or treatment plan. And once that's reviewed, the primary care physician delivers that diagnosis or treatment plan or any recommendations back to the patient, and any patients that have high-risk needs are fast-tracked back into our dermatology clinic. So we launched this program for a couple very specific reasons. We had really bad access in our dermatology practice and wanted to see if this would be a way to get patients better access to the care. The time that it was taking to do a consult, we thought could be more efficient through an e-consult process. And we had a high rate of cancellation, which was an indication to us that patients felt like when they received a dermatology consult, they either felt there was a better place to get it that was more convenient for them, or that they didn't feel like the dermatology consult was necessary. And so what we found in running this, we started running a pilot on it and actually published a study out of it that is at the bottom there. We ran this for about a 6-month period and found that we were able to reduce the time to diagnosis from 23 days down to 16 hours. We were able to reduce the average time that the dermatologist spent on the consult, went from 25 minutes, is what you'd see in an in-person appointment, down to 8 minutes through an e-consult. 73% of the e-consults, or 73% of the dermatology conditions were resolved through e-consult. So that means, we talk a lot about substitute versus supplemental care when we're looking at the regulatory framework. This is really good proof that it was not just supplemental care. It was resolved through the e-consult, indicating that 27% of those actually had to come in for a dermatology appointment. And we saw a 50% lower cancellation rate. The numbers behind that are dropped from 22% down to 11% as a result of using the platform. So patients felt more confident that when they got a dermatology consult, they actually needed to come in for the appointment. As I mentioned, this is an area where I bring this up as an example primarily because from an interprofessional consult perspective, we think this is exactly where that new physician proposed fee schedule will be applied. And actually, we're optimistic that the rates that were proposed align really well to the operations. I won't say that that's true for all of the parts of the physician proposed fee schedule, but as you saw, that this is really aimed at making it so that patients who would have otherwise ended up getting an E&M visit in dermatology no longer have to do that. And the physician proposed fee schedule, the work reviews that are related to that, I think are really representative of the work that we saw in this pilot study. Second, I want to talk a little bit about our video visits platform. So we have a video visits platform that's integrated on the left. As a system, we use Epic. That leftmost picture is our patient-facing application. Then to the right of that is what the patient would see when they initiate a video visit, and then even more to the right is what the physician would see. So we integrated the video visit platform in this manner for a couple of different reasons, but primarily because it offers the patient allotted flexibility in being able to launch it directly out of the app. They don't have to download a separate app. We have over 500,000 users of our application, and so you have a captive audience that's already used to using your app. And on the physician side, it should feel very much like operating just within the clinic. So if a patient were to walk in, you're sitting there documenting into Epic. Instead of that, a video visit pops up and you're able to conduct the visit through video. The other reason for this is that I'll get into it a little bit more, but we have a lot of very specialized uses of telemedicine at Stanford. So, anything from preoperative to postoperative, and whether you're doing that in GI oncology or interventional radiology, there are very different clinical flows that we had to apply, ways that those patients were scheduled, expectations around how the staff works up the patient. And so this allowed the technology portion of it to be somewhat frictionless. And that's a lot of what I'm trying to get at today, is that specialty video visits at a health system are not always the same as the ones that you're seeing being largely brought up by some of the telehealth vendors or even the health plans. So on the left, you can see that a couple of the different programs, but we've launched video visits in 30 different 30 different departments, and we have more planned in 2018, but they're a pretty diverse set. So as you can see, we have primary care, telestroke, addiction medicine, psych. Some of the ones at the bottom, like cardiovascular medicine and GI post-acute follow-up, have required some really specific build to make sure that video is a good application for the patient. One other thing that I'll point out about our integrating video into the app, the way that we did it, is that it allowed us to blend between multiple modalities of care. So there was a lot of demand for video, and I think part of the demand for video is driven by a regulatory perspective. So you see that a lot of the requirement says that you have to have audio-visual capabilities. But whether it's Stanford's data or vendor data that you're looking at, you'll see that patients still interact primarily through text, email, phone, rather than video. And this allowed us we get about 600,000 My Health messages a year from our patients and many, many more phone calls. And it allows us to blend easily based on what the patient wants. So we're not pushing them into different platforms depending on what modality they want to use to interact with the system. So I'll describe a little bit about a way that we applied it in an innovative manner into a primary care clinic. So a little bit more about Stanford. We have a 50,000 person ACO, and there was a large chunk of that population that didn't interact with the health system at all. And so we categorized those as low and rising risk patients and wanted to find a way to better engage those patients with their primary care provider. And so we issued a health risk assessment to them and defaulted them into a virtual care setting, and we call that ClickWell Care. And so this is, at least when it was initiated in 2015, was the first known implementation of a technology-enabled primary care model. And so in the period of 2015, we had 1,207 patients complete a visit as part of the program. And it is described as a bricks and clicks model of care where the patient is able to interact in the modality that they want to. So we saw, as you can see up there in the left in white, a lot of patients still decided just to come down into the clinic. A lot of patients, even more patients, did some blend of phone and clinic, and then we added video in there a little bit. But the insights that we derive from that, I think, are important, which is that patients who lived further from Stanford Healthcare did use technology more frequently, which is to be expected. But a lot of patients who live within 5 miles of Stanford also chose to use technology. And I think that for us, this was a good indication that there were some patients who felt that establishing that physician relationship with their PCP was really important, although many of the on-demand or episodic needs that they had could be served potentially by video visits or a phone call, and it was important to think about how we could blend those pieces together. I'll also point out that this was a potentially interesting way for us to engage more of our patients virtually. And one of the interesting findings was that young men were more likely to interact virtually than any of the other populations that we saw. There's a lot of studies out there that show that this population doesn't traditionally interact with the healthcare system. And so it was a way for us to find that virtual could be a way to get at hard to reach populations, leaving kind of an open idea that regulation should, as you think about this program as a way to segment different patient characteristics, different modalities, it's important that the regulation allows for us to use that on different care settings. So we don't always know the best diagnostic category before you launch these things that patients will want to interact with. I'll talk a little bit now about our telestroke program. So telestroke's been around for a really long time. We're not, many different systems interact with this. We've done it since about 2015, so actually relatively recently. Our goals with it were to expand our stroke and acute care capabilities through telemedicine, to complement our existing systems of care, and to provide comprehensive support to our community providers. Now, the interesting piece about our telestroke program actually with this is that we wanted to get really close to the regulations that were happening as the bipartisan bill and the FAST Act were getting passed to see how the bill was actually being structured and whether that lined up with how care was actually being delivered. And what we found with this is that in early iterations of the bill, there were actually restrictions around the timeframes that TPA could be administered, one of our neurologists it was actually publishing a study at the time that showed that you could have effective endovascular intervention up to 24 hours after an acute stroke. And so a lot of the feedback that we were giving on the bill was to expand a 4.5 window to make it just open so that it could evolve with how stroke care is actually being delivered. But getting into this was into the kind of sausage making of the bill process was incredibly insightful for us. And also, we felt like it gave us a better ability to see where the bill was headed. So the bill didn't drop, and then all of a sudden we have to realize how telestroke is, or how regulation might impact things like our business model. So it's great that we can now bill for this, and we think it'll allow us to expand out to a bunch of different sites. But it also made us have to react to sites where we had already sold it, whether that was through subscription models or other ways, so that we could effectively transition those programs into a more modern way and start to scale up. So I'll tell you quickly a little bit about the findings that we have from this program. We've done 507 consults, and that's in about a 3-year period, and we've scaled up a couple different programs through that time. 114 of those were video consults. The remainder of those were through phone, and have administered TPA on 36 different cases. Over to the right of those 36, so there have been 46 total acute treatments, 10 of which were endovascular treatment. And what we found is that when you assess the patient through video and decide to transfer them back to the site, there's a concordance rate of about 80%, which is a good indication for the sites that we're bringing it to and for Stanford that we're bringing the right patients back to the site. So what our community providers didn't want to see is that we were unnecessarily pulling patients out of the community to bring them back to Stanford. And so this concordance rate has been really supportive for us to show that the program works very well. I now want to talk a little bit about a second opinion program that we launched. And we've talked a lot about different health disparities that exist between rural and urban communities. And I think that this program really got at that for us in a way that we wanted to leverage our specialty care out to a broader subset of patients. So just to make sure, these are second opinions, sometimes called expert opinion or medical record review. There's a lot of different names that are used for this. But what we found at Stanford was that we were getting a massive demand of patients that were calling our physicians through really informal channels, whether that was email or they were just calling our call center to say, I've received a really high acuity diagnosis. I don't know what to do about it. And before I embark on what is a really expensive and time-consuming and potentially frustrating treatment plan, I want a Stanford physician to validate that treatment plan. But in the previous state, it felt very informal. It felt like you had to know the doctor, know someone within the system in order to get that in there. A lot of our physicians were actually using third-party apps to render these. So third-party apps were reaching out to our physicians and asking them to conduct second opinions. And our patients felt like that was a really inconsistent way to leverage the Stanford brand. And the other piece is it was a really inconsistent way for those physicians to leverage their malpractice insurance. They weren't generally covered. And so actually, one of the biggest parts of us launching this program was not the implementation. It was figuring out how to rewrite our entire faculty practice policy and create a new funds flow model to compensate physicians fairly for the care that they were delivering. The other piece is that on the patient side, there was no clear expectation around pricing, and patients spent an incredible amount of time collecting their own medical records. And Administrator Verma did a great job describing, and she's referenced her husband's condition in another speech that I heard her describe, is that during that condition, they had given her, I think it was a DVD of medical records, and she effectively said, what do I do with this DVD of medical records? And we experienced that a lot with our second opinion program, where when we reach out to a patient and say, great, we'll render an opinion, just go get all your records from your previous provider, including your CT, MRI, and all that. They have no idea how to bring that back to us. It takes many, many weeks, and oftentimes it's incomplete. And so we decided to launch a second opinion program to deal with a lot of those different issues. So the way that the program works is the patient goes into an online portal, uploads information about themselves, including their previous diagnosis. They actually upload their local treating physician in the platform as well. We then, at that point, have a vendor go out and on the patient's behalf, collect their medical records, synthesize it so that it's a very clean packet of information that is then delivered back to an expert on our end. That expert can then go through within a portal. If they need to look at CTs or MRIs, they have a DICOM viewer that they can go into. It's all outside of Epic in this case, so which was one of the pieces of feedback that we wanted to that we actually heard from our physicians was keep this as a really lightweight integration. Obviously, if the patient decides to come to Stanford, we need to bring in all the medical records at that point. But if you're just rendering a second opinion, it's okay to leave it all in a different system. And then at that point, once our experts delivered a second opinion, the opinion is delivered by the vendor actually back to the patient in an online portal where they can review the second opinion. They know a lot about the physician that wrote it up, a lot about the next steps for their treatment or condition. And I think equally as important is that their local treating physician can review those next steps with them. You see that a lot with genetic testing today, where you get some information that might change how you want to proceed, but you have no idea with next steps. And I think that's really important with telemedicine as well, is that if you do an on-demand or if you do telemedicine and it results in that you're going to need something else, the better you can make that transmission from episodic and primary care into the specialty setting, I think the more satisfying and the higher utilization we'll get as health systems. But the result of this has been very good. It's lifted a lot of the burden. As I mentioned, it allows our physicians to practice within their malpractice limits. And we were able to put our Stanford brand on it, so patients that were specifically seeking out a Stanford doctor now know exactly what they're getting. So I'm going to get into a little bit now about some of the barriers to adoption that we see. I'll start by saying that health systems use telemedicine for a variety of different reasons. A lot of, it can be from creating access to creating a better patient experience, a stickiness with your brand, creating a better network of care. As I mentioned with the PhotoCare MD platform, I think that specialty centers in particular are trying to figure out how to augment their network of care so that e-consults come back in and that the network of care is maximizing their license and that only the necessary cases that need to come back to the hub are coming back to the hub. Cost savings, better continuity of care. Administrator Verma referenced that we need to deliver this in the context of the patient's total care. But the reality is that all of these strategies might require different modalities of telehealth. So it's really difficult to regulate for the diagnostic groups that would be well served to fit into these areas. And I think particularly so in a complex health system where you have many different departments and many different workflows. I'll share a little bit of a story, which is I had seen for probably 5 different years telehealth projections that say things like telehealth, healthcare will be 50% virtual by 2018 and healthcare will be 50% virtual by 2020. And so it really rocked our world when Kaiser Permanente's CEO in our local market said, so we are now over 50% virtual. And the whole organization went out and said, we got to catch up. What are we doing? We're not even close. And I'll provide kind of the other context, which is in 2018, they published a study that said less than 1% of that care is actually done through video. And for me, this highlights the disconnect of how do we define telehealth, because that was a big relief to our system because we do the way you categorize telehealth. We do 600,000 My Health messages a year, many of which the patient is demanding care, and we're trying to figure out what is the balance between a patient asking for care to be driven through a My Health message and what the provider is willing to do with that message. And there's massive care teams that support that effort. We do tens of thousands of phone calls, but we also do less than 1% of video, and so, as we consider the barriers to adoption or how we're building these programs, my takeaway from this is actually that the physician proposed fee schedule rules and the way that they kind of differentiated between telehealth and interprofessional consults and virtual check-ins is a really forward-thinking way to do it. It doesn't capture everything, but it does a good job of recognizing this problem, which is not everything is best served through video. And I'll highlight specifically for our organization what some of the common barriers to telehealth have been. I always start off with reimbursement. Reimbursement continues to be by far and away the largest one. We're in a highly consolidated market, one that tends to have large fee-for-service reimbursement still, and it is incredibly difficult to know which codes you can bill, even ones that are bundled. So it could be a preoperative or a postoperative visit, and it's supposed to be bundled. The reimbursement is bundled, but our compliance and legal departments regularly share, Medicare doesn't cover this, so we really shouldn't. We should follow Medicare billing and reimbursement guidelines and not bill this. And the point is, it's free, it's bundled, it's better delivered through telemedicine. We save our patients a 30-minute, sometimes 2-hour drive over to the clinic, to find parking, get out of the car, all of that. And yet we have a really hard time with reimbursement still. Provider compensation, which is if you do get creative with the reimbursement side, you have to make sure that it feels right on the provider side. So a lot of systems have experimented with paying providers the same as if they had done it in person. But as we know, the times go down a lot of times with telemedicine. So 8 minutes versus 25 minutes. And then you get into kind of a revenue sharing question, which is how much of that does the physician take? How much of that does the plan take? Does any of that go back to the patient? That's been a really hard question for us to solve. From a provider ROI perspective, I think we're increasingly seeing that value-based systems are able to deliver telehealth in a much bigger way than systems that are on fee-for-service. And we're even seeing that in a plan setting. Medicare Advantage and Medicare fee-for-service that Representative Eshoo outlined is a great example of that. And then health plan contracting. And I won't go into too much detail there, except for that in my experience, there are different telehealth codes between every single health plan. There's different modifiers that they require, and then not to get into the fact that you have different Medi-Cal and Medicaid programs. It makes it incredibly difficult for a health system to set up a consistent program because you have to bring in patients and create back-end workflows in order to be compliant that are incredibly burdensome. From a liability and licensure perspective, the state-by-state licensure requirements are extremely stringent. So we know that there are specialty cases that we at Stanford could treat that could come in. They're sitting in a rural community, whether that's in Nevada or Alaska or wherever that patient is, that our physicians can't treat. And you have two real options, which is you hire an army of credentialing and licensure specialists and try to get your physicians licensed in lots of different areas, or you continue to deliver care in your state and really remove what is the intent of telehealth, which is to expand those specialty services more broadly. And I talked a little bit about the licensure and practice of medicine, but we get into that a lot, even with our second opinion program, where we had to decide whether or not we were actually delivering care. Was there a patient-physician relationship established through that program, even if the patient never directly talked to the patient, and the resulting risk that our physicians take on as a result of that. From a regulatory perspective, we've heard a lot of these already, but I'll just point out a couple of different things, which is the documentation and administrative requirements are very burdensome, and the vendors are incredibly nimble and have been able to find a way to navigate these pieces. But even the way that technology is allowed to be used is somewhat restrictive. And as I mentioned, I think that a lot of the use of video to date has been because most of the legislation says you have to use audio-visual technology. And there are weird loopholes that you can get at, which is you can have video capability and then default back to phone and still meet that requirement. But I still think video is being pushed really heavily in some settings where it doesn't make sense clinically as a result of that. And then from a workflow perspective, this is what I described at the first part, which is a lot of this is last mile stuff. You have to figure out how to enable the clinic and administrative teams to tell patients that they are able to schedule for video visits. When is it appropriate to schedule for a telehealth visit? You have to integrate it into the physician's workflows and make decisions around, do you sprinkle it throughout the physician's schedule, or do you have one physician that's just dedicated to doing telemedicine and knock those out all day? From a engagement perspective, this does require you are changing the behavior, you're changing the ways that patients use telehealth. It requires marketing, it requires letting them know these are the conditions that are really well suited to use telemedicine. And then from a technology perspective, I used to say that technology was not an issue with telemedicine, that it was largely the other problems. I don't say that as much anymore because I've found that with video, there's a lot of barriers that we run into around different browsers being able to launch, whether you launch it web-based or whether you hold your servers on site. And it only takes what we've found is one really bad experience for some of these physicians before they say, like, listen, I told you so. This is just not good stuff. And that holds true for the patients as well. So I'll touch a little bit on another point, which is the difference between coverage parity and reimbursement parity and how that impacts reimbursement. I'll talk specifically in California and hit on this one little clause that you see there at the end, which is California, when you look at different organizations that talk about parity and whether you get reimbursement, is considered a good state, right? We've got coverage parity. You're supposed to cover telemedicine the same way that you would in-person care. However, this little clause at the end that says subject to the terms and conditions of the contract has really thrown a wrench in that for us. And it's the right clause because you do need to leave the health plan the right to negotiate with the provider on a lot of different things. But the way that this gets used in application, I think, is really interesting, which is the majority of payers still pay for telemedicine. If you send them a bill with a modifier that indicated that it was telemedicine, the majority of commercial payers will pay for it. But we also are starting to see a lot of this, which is what I would consider to be diversionary telemedicine, which is a denial that says you're able to use telemedicine through our system, but not at your health system. We have a deeply integrated telehealth provider. If you want to use telehealth, use it through our provider, but we're going to deny it if it's with your health system. And I think this is something that we really need to push back against because it means that you're not able to use telemedicine with your doctor. It means that you're not able to continue on and use telemedicine in a specialty setting. You're only able to use it in an on-demand or episodic basis. And really what's going on here is that the plan is using this to effectively channel cases as an initial touch point into different narrow networks. And whatever your perspective is on whether that's a good or a bad strategy or whether that's good or bad for healthcare, it's an important piece to acknowledge that telemedicine is being used as a spike in some cases to do this. I'll talk a little bit about why I think telemedicine is different when it's provided in an academic in a health system setting, which is you're able to access your in-network providers. You get specialty or higher acuity cases than what you might get through your health plan, and you have better continuity of care. So I've heard that described as a patient shows up and they have a cough. You can probably solve that episodically, but if they showed up 10 different times with a cough, that's something you probably want to track and intervene. And beyond that, being able to have a specialty network that when things get serious, you don't just say, that was a great telemedicine experience. You do have something more serious. You need to go to the ED. You need to go into you need to go see a cardiologist, whatever it is. There needs to be a clean handoff. Otherwise, I think that experience feels really disjointed for the patient. Here's a common list of on-demand solutions that are offered. This is what a patient might see if they were getting telemedicine through their health plan. And as you can see, they're largely general health services, largely on-demand. And when you see that when you see different systems that are saying they're doing 1 million or 1.5 million visits through telemedicine, they're largely for these types of conditions. And please don't misinterpret me to say that I think these are bad conditions. I think these are there's a reason that large health plans are offering telemedicine. It's really good. It's really good to have access to this episodic care. We know that it avoids ED costs. We know that it avoids urgent costs. Health plans might not be set up always to provide this, and a lot of times these vendors are actually powering the systems for health providers. And so I'm not saying that these are not really good, necessary service, but it just represents one slice of how telemedicine is being used. And we will see adoption grow in this area because there's a really clean use case for it. But there's lots of other preoperative, postoperative ways to use telemedicine that make a lot of sense for health systems that are not represented in this list. And it's important I think, for health systems, vendors, and plans to talk about that with a consistent voice as you're building telemedicine regulation to make sure all of those use cases are represented. I touched on this a little bit already, but this is effectively what you'd see if you got your telemedicine through your health plan. You get faster access to preventative services, saves you time and money, keeps the employee in the office, and it reduces ED and urgent care utilization. as I mentioned, it's important once you get this, what we get calls of all the time, which is, I got this Teladoc console, or I got this, whatever the company is, and they said that I need more high acuity services. And now our provider, there's no referral. Our provider doesn't know really what was said in the initial consult. And so it's something to consider for that handoff. I think there's an opportunity there for better handoffs in these cases. So I'll talk a little bit about how health systems might be impacted by future state, some of the areas that Krista outlined. So the first one is around Medicare Advantage. So this is actually a shot of our health benefits through Stanford's Medicare Advantage plan. We have a really small Medicare Advantage plan. We currently offer telehealth as a supplemental benefit, but starting in 2020, we've already filed to offer it as a Part C benefit. And so this is what you'll see. I think you'll see very quickly, most Medicare Advantage plans are going to offer something like this because it makes business sense. We know that from the integrated payers that are doing that. We know that from the large self-insured employers that are offering telemedicine. And so we'll see the same trend, I think, happen with Medicare Advantage plans. And we're really supportive of that move. We think it's a really good thing. There's, many patients are covered through Medicare Advantage plans. We do have a few different concerns, which is around who gets to determine what's clinically appropriate through telemedicine. If you're able to determine that there are certain diagnoses that you can get through telemedicine and other ones that you cannot, that's effectively saying no coverage parity. They can say you can get on-demand services, or you can get these services that have proven to be valuable, but you can't use your health system, or you can't use areas where there's no literature that shows that it's clinically appropriate. And the other one is around what is the definition of a contracted telehealth provider. We don't want to see this as a way to say that similar to what I described with large self-insured employers, as a way to say you can get telemedicine through your Medicare Advantage plan, but only if it's with a vendor that we're deeply integrated with. We think it's important that those Medicare Advantage patients continue to be able to get telemedicine at many different providers. And I'll touch a little bit on, I think, the trend that Congresswoman Eshoo talked about, which is what happens when telehealth is a reality for Medicare Advantage patients, but not for Medicare fee-for-service. And on the left, you can see that Medicare Advantage as of 2017 still only represents 33% of covered lives in Medicare. And it's really inconsistent on a state-by-state basis. And what that means for providers is that you're faced with back down to that workflow piece, which is patient shows up and they say they have Medicare. You have to, at that point, identify through eligibility or set your program up in a way that is consistent so that you can offer telemedicine to patients with Medicare Advantage, but not for patients with fee-for-service, or you have to create a self-pay rate, but it's incredibly burdensome on the provider to figure out the difference here. And I think it's a reality that we'll encounter in 2020, and it would be really awesome if we could address this before that comes around so that all patients can do it. To me, I'll get into it a little bit, but I think this is really an accounting problem and a budgeting problem more than it is a clinical necessity problem. I think we know that this stuff is valuable, and we just need to figure out how to make it make sense from a legislative perspective. Krista did a great job covering all of the different Medicare proposed fee schedule. I'll just highlight that on a couple of reads that we have initially from a health system perspective, which is for the virtual check-ins, we originally thought this might be a way to manage those 600,000 messages that we get from patients every year, but it looks like it's not a particularly good fit for that, in that you both have to have, I think that it requires that you still have to have a phone call, and it's also can't be pre or post a very specific subset of days. So it's very difficult to track. Did you have a visit within 7 days? What was the like diagnosis? And you have to do all that just to get $14. So it's pretty difficult to see that the reimbursement aligns well for us. We think it's a great idea, but we want to continue to track both the reimbursement and the requirements of what is a billable provider. So right now, a lot of times nurses or different individuals are reading these messages and talking to the patients. And so the requirements around billable providers, I think, will drive adoption with this code. Interprofessional consult, as I mentioned, we're largely supportive of this. We think that this is a really a really, really strong move in the right direction. As a referral center, we get tons of what we would love to do as the e-consult business, whether it's in dermatology or many other service lines that we'd like to expand it out into. And I think that the proposed work RVUs are in really close alignment with what we've seen to be fair reimbursement for this. And the only piece that we want to continue to monitor is how to message to a patient that you might be getting a bill from a billing provider that you've never met before. I think it's something that we can get over, and there are already verbal consent requirements notated in this, but it'll be something that we'll continue to have to message to the patient, which is you might get a bill from someone that you have no idea who they are. And then on the effectively the asynchronous piece, this is the direct to patient asynchronous. So this would be like teledermatology, but patient directed rather than primary care physician directed. We think this is a great idea, and we think it's, this is, as you talk about scale and innovation and the ability to leverage physician time in a way that you couldn't before, there's a ton of opportunity here. And the question still in our mind is just, does the reimbursement line up in a way that makes sense to put, whether the physician's on call or not, or doing it in their free time? I think the dollar amount was like $12 or $14. So we'll have to figure out whether or not that's a good indication of the reimbursement that should be there. But nonetheless, we really like that it was recognized as a modality of delivering telemedicine. So I'll touch on finally a couple of future state opportunities. So I'll admit that, when Andy Coe, who's our Chief Government Relations Officer, started bringing me out to DC, I had no idea of how DC worked or how these bills worked. We just had a couple very specific telemedicine programs that we wanted to go figure out how is legislation going to impact our telemedicine program. And these are some of the learnings that I've received from, kind of going around the Hill, which is Congressional Budget Office scoring tends to kill telemedicine bills. And we know that we're headed towards value, and we can talk about what the definition of value is. I think there's a huge difference between, for example, being fully capitated and then having some limited upside incentives, and the result that that has on telemedicine is huge. But in today's world, we are still 75% fee for service. And so we need to figure out, if we want to make telemedicine a reality today, we need to figure out how to pay for it in a fee-for-service setting. And this is where I said I really think that it's an accounting error when we say that if you score this stuff on the Medicare fee-for-service side, it comes through as a massive cost. If you score it on the Medicare Advantage side, it comes through as a savings. That doesn't make any sense. It's the same care. They're accessing the same care. And frankly, just the beneficiaries should have access to the same services. The few things that I've learned out of that are that they talk a lot about substitute versus supplemental visits, which are the difference between telemedicine visits that are in lieu of what would have been an in-person and then additional ones. The only commentary I'll make on that is that to the extent that supplemental visits are categorized as are largely preventative services, we really don't agree with the fact that preventative services, whether they're supplemental or not, are an additional cost. And that leads me into downstream cost avoidance, which is the CBO has a very limited ability to project out what the total cost savings of these programs are. They can't say that if you do some telemedicine that you're going to let someone live for an extra 5 years and that here's the resulting total cost of care for the lifetime of a patient. Health plans and self-insured employers do start to model that out through actuarial, but the downstream can't be scored, and as a result, we'll continue to see this be a problem. We talked a lot about 1834M, but for me, when I first saw this, it felt a lot like when people would say 401k, which is like, what are the 1834M restrictions? And no one knows actually where that comes from. It comes from a very specific part, Krista outlined from the Social Security Act. But really, my takeaway here is that patients should be able to get care when they're at home. We know that makes sense. Whenever you describe a telemedicine program, you're envisioning a doctor and a patient sitting there on their iPad or iPhone sitting at their home. And so we need to make sure that this is removed. And then also the metropolitan statistical area restrictions, which is, you're asking systems to set up programs that are for very, very specific rural communities that represent a tiny portion of the population. That's really hard to do when you have a lot of those same patients that are sitting right in your same urban community, and it's hard to make those investments. So I think this is Krista said it well, this is the linchpin to getting coverage for fee-for-service. So to the extent that we can continue to push on 1834M, I think that that'll make for much broader telemedicine adoption. And finally, I'll just give a couple different takeaways for health systems and some potential next steps to consider, which are continue to highlight those areas where you see demand for these types of services. I think health systems are really well served to represent the patient voice where they see patients interacting. As I mentioned, we see it through our My Health messages. And the more that you can relay that back and describe that type of demand, the better. The middle, which is share those specific use cases, and if you can see those bills before they evolve, I think that the ability for our telestroke program to be successful would be much different if the TPA window would have remained at 4.5 hours than if that had been removed. And it also allows you to really budget for these programs and know how it's going to impact you when the rubber hits the road and you actually have to operationalize them. And then, like I said, go after the 1834M restrictions. I think that we all would benefit from getting rid of those. I'm happy to take a couple questions with the last, I think we only have 5 minutes, but happy to open it up for questions if anyone has any. Yeah, I would actually say that we haven't done a ton of it. Our programs have not had broad enough adoption where we've dealt with a lot of the credentialing, where we're putting people at different sites and credentialing them. It's been more of a licensure issue where you're saying, can you we have someone coming in from Nevada, or we have to identify where that patient's coming from. So it's been more licensure actually to date for us. Great. Well, thank you so much. Thanks.
Thanks, Chris. Okay, we have 3 sessions left. We're going to eat lunch until 12:30, and then we are going to hear from Dr. Neil Evans from the Veterans Administration, and we're going to hear from American Well and NYP and MD Live. And for those of you who want to stay for the discussion, just if you have questions about all of this, I'll be here for the Q&A period. It has turned to rain outside. I know some people had to leave because where they were from, there was snowing, but here it's rain. And as promised, I did get the address where all the slides will be, www.connectwithcare.org. That's our website. /2018 Hospital Summit. And there is a live cast. I think that it stays on YouTube forever. So if you want to recap anything, it's on YouTube. So anyway, I welcome you to grab some lunch and take a break. Okay, we're going to get started with our program, our afternoon portion. I want to introduce Dave Ryan, who's the General Manager of Health and Life Sciences at Intel. Dave has been a great champion of the Alliance for Connected Care and a great spokesperson for telehealth in Washington. He's made the rounds, the White House, OMB, HHS, CMS, and he's really got the pitch down to all the lawmakers about how important telehealth is. So at Intel, he runs the Internet of Things healthcare group and helps the global and health life sciences device industry transform healthcare. His customers are manufacturers who build life sciences research instruments, as well as medical equipment, appliances, and devices that are used in hospitals, and has been really dedicated to moving data and ensuring that patients have access to their data. So we are pleased that Dave is here, and he's going to introduce our special guest, Dr. Neil Evans from the VA. Oh, and I should mention, in this session, we are going to have questions.
But it appears we have no fireplace for our fireside chat. I mean, being from California, I was sort of hoping for that. Yes. Good afternoon. I hope you all enjoyed lunch. The Veterans Affairs, VA, 9 million veterans cared for by this system. And I think we all know that it's the largest healthcare provider in the country. But still, people are still surprised to learn that the VA is the largest telehealth provider, one of the earliest movers in telehealth, has over 900 sites and handling 50 different specialties through telecare, teleremote services. Dr. Neil Evans is the Chief Officer of the Office of Connected Care at the VA. You've been in that role 6 years or so, at the VA about 17 years. He's board certified in internal medicine and clinical informatics, and also has a leadership role in the VA for clinical informatics. And after his chemical engineering degree, he got his medical training at Johns Hopkins and has a faculty position with Uniform Services University in Medicine. And as if that's not enough, Dr. Evans is a practicing clinician here at the DC VA. And as we were talking about this panel, I found out that, and I want to confirm, were you really texting me and emailing me in between patient visits? If it was during them, would I get a consult fee?
Well, not in the VA, right? We
Yeah.
are spared some of that.
I also understand you're an avid bicyclist and you bicycle to work. Did you bicycle to us today in this weather?
Yes, I am a bike commuter. I bike about 16 miles a day back and forth to work. But I have an agreement with my wife. This is my one agreement when I started bike commuting about 10 years ago, that I wouldn't bike when it was actively snowing. So I would have come on my bike today,
Okay.
but I got to keep my agreements. I
Right.
wasn't expecting snow in November.
No. Well, we'll warm things up a little bit with a couple questions, but we would really like to have questions from you all. And so start getting ready. And then where is the gentleman with the microphone? Right there. So if you flag him down, then we'll be able to hear the question. But first, so Connected Care, the VA, what is the scope of this that you have, the scope of remote care that is deployed, and what's the status of what you really have deployed operationally?
Sure. So I'd like to start with what our vision statement is, and that's that access and the veterans' experience will be enhanced through health information technologies that are integrated into the daily lives of veterans and VA staff. And so for us, there are, we sort of prioritize two things. How do we use this to increase access to care, and how do we enhance the experience? So we talked a little bit in one of the earlier sessions about the consumer experience engaging with healthcare. We believe that technology can really change the experience of veterans and actually of healthcare providers, but only if it is meaningfully integrated into people's daily lives in a way that impacts the quality of outcomes that patients have when they engage with us through our connected care technologies, and if it makes sense for our clinical teams. I think Chris spoke a lot about the importance of thinking really carefully about how this is implemented on the front lines, so that clinicians view this as a value add and not an added burden to their daily existence. So our connected care program, we think about all of our digital properties. Chris mentioned this. I think a lot of times we do get stuck a little bit thinking about telehealth in a more constrained fashion. That's one of the reasons I like the term connected care. It highlights what we're really doing here. We're simply using technology to increase the connections between a patient and their trusted healthcare team. It's I often think that the primary what we're offering for the most part in healthcare is a relationship with somebody who can help advise you and direct you and give you the tools to help live a more healthy life. And this is just using technology to make those connections more real. So we think of it really across the spectrum, not just video care. We start with our online portal. Our online portal, we have around 8 million patients who get care from us every year. We have 4 million of them have an account on our portal. 2 million of them, more than 2 million, 2.1 million, are using some of the advanced features. There was a mention of secure email messages back and forth. We last year had 14 million messages exchanged between patients and their healthcare teams across the enterprise. So that's a big piece of the puzzle. We have a mobile health program, and then we have our telehealth program. So we'll talk a little bit about the telehealth program, and I think there's a lot of different ways that you can think about what telehealth is accomplishing for you. We think about telehealth either by modalities, the location where care is delivered, or what it's accomplishing for us from a business perspective within the VA. So I'll kind of go through each of those in turn, if it's helpful. So first, modalities. We have a pretty sizable, I'll give you the sort of the top line numbers to give you a sense for telehealth in the VA. We define, when we're measuring telehealth specifically, not the broader connected care, we define an episode of care as either a visit that is completed by video, a store and forward asynchronous encounter that may go back and forth a few times but has now arrived at a resolution for the patient, or a full month of remote patient monitoring in the home. And last year we did so if you add all those up, the visits, the store and forward encounters, and a full month of monitoring, we did 2.3 million, just over 2.29 million episodes of care last year. 782,000 veterans. That's 13% of our patient population received at least a portion of their care through one of those modalities, either a video visit, a store and forward encounter, or remote home monitoring. And we do that in more than 50 clinical specialties. I like to say, if we deliver the care, we can figure, with some small exceptions, but we can figure out a way to do that remotely, or at least deliver a portion of that care remotely in a way that makes sense for veterans. So that's how we think about it from a modality perspective. We also think about it from the location of care. Much of our telehealth program, probably the vast majority of it, has been connecting our remote community clinics, of which we have 1,200 or so around the country, to one of our main medical centers, one of our primary medical centers. So connecting specialists or primary care providers, or really any provider, who are maybe housed or based at the medical center with patients who are often in a more rural area, and one of our community clinics. So that's where a lot of the care has been, and I think we can tease a little bit more about what that looks like within the outpatient environment. We have two other areas that have been big focus areas for us and are becoming increasing focus areas. One is the use of telemedicine to enhance inpatient care. We run a rather large tele-ICU program. Of the 1,700 ICU beds in the VA, 300 of them are monitored full-time from one of our tele-ICU hubs in either Minneapolis or Cincinnati. And we're expanding our footprint of using telemedicine to enhance inpatient care, to include a telestroke program that we launched in 2016. We're working on other specialties where we know that there's often a need for services, sometimes at a rural facility where we may not have, where a nephrologist, for example, at one of our rural hospitals can't take call 24 hours a day, 7 days a week, 365 days a year, and having somebody available to help with dialysis, decisions about whether to start dialysis or something of that sort remotely may be of value. So that's the inpatient side. And then the other side, which is really a huge focus for us at the moment, is increasing care delivery into the home. Our secure messaging that I mentioned in the portals, 14 million messages last year, that's obviously happening in the home. But with regard to telemedicine, video care into the home, last year, 2 years ago, we looked at our numbers and we had 12% of our patients were engaged in some form of telehealth. But this gets back to what Chris mentioned as well. Less than 1% were receiving any of that care in the home via video. And we don't believe necessarily that that should be 100%, but we think it probably should be more than less than 1%. And there were several reasons why that was the case, but that's an area where we see a lot of room for growth, for thinking about what care can be delivered by video or could be delivered in other modalities asynchronously into the home via telehealth.
That scope is enormous. It's not a small POC or a pilot that can be hidden from the organization and leadership. You must have very strong leadership air cover for the digital connected care of the VA. Why is that? What's the perspective from institutional leadership on these initiatives, and how does that translate for you in terms of getting things done?
You're exactly right. This is the VA leadership would consider telemedicine, virtual care, connected care, choose your title. I don't really care that much, but which you choose, as mission critical. And I think part of that is there are several reasons. Number one, we are a healthcare system that by law needs to deliver care to veterans in this country wherever they are. And so we have always had to manage a situation where we need to deliver care to locations where we don't have a robust brick and mortar presence. And so the incentive to be able to deliver care virtually or to help manage at least a portion of our care demand virtually has always been very high in the VA. The first telemedicine visit in the VA happened in what year? Any guesses? I told you ahead of time, so you can die.
Yeah, I could cheat. So guesses. What year is the first VA telemedicine engagement? 1965. What did? 2005. Earlier.
1959.
Yep.
Two-way black and white television, mental health visits delivered between the University of Nebraska and 3 VA facilities in Nebraska. It was published, so it's actually in the literature that this was a telemedicine engagement. Now, I would say that our rate of adoption between 1959 and 2003 was rather slow.
Standard rate of growth at that time.
It was standard rate of growth. But there was a bit of a, in that time period between 1959 and 2003, technology changed rather.
A few things happened,
Yeah, a few things happened,
yes,
right?
Internet.
Intel made a few chips, if I'm not mistaken, somewhere along in there. So as technology started to be able to allow us to meet needs virtually, it was in the early 2000s, around 2003, that we really started to invest significantly in telemedicine. So again, to meet the needs of rural veterans, but also, and I think of that we think of that in a couple ways, and leadership would express this as well. Telehealth helps us make healthcare more accessible, not just in rural areas. It is a universal fact that when you go to, I think, any healthcare system, that patients complain about the parking, and the VA is not immune from that problem. And so I think whether you're in an urban area or a rural area, from the standpoint of accessibility, making care more accessible to your customer, there's value there. But for us, it's also an ability, it's also something that allows us to better match supply and demand as a national healthcare system. We can hire providers in places where it's easier for us to hire healthcare providers and deliver care to places in this country where we have tremendous difficulty hiring certain subspecialists. And so for us, it's not just about making care accessible for patients, it's also a staffing strategy that helps us build capacity across the system. And then it's also a way that we believe we can increase quality by matching patients to the provider within the VA healthcare system who is most uniquely capable of meeting their needs. This is similar to a second opinion type program, but ways we can match patients with their providers.
What was the journey for your clinical staff, the physicians? Constantly hear about resistance to new models. But what's now this year? You're at fairly large scale, so you're not talking about a pilot that might have a lot of resistance. But talk us through how that worked with the clinical staff, and do you have any pushback or challenges today with the staff?
Yeah, so I think first of all, this doesn't happen, it's not magic, right? You can't turn on the telehealth switch and expect it to happen. Just to give you an example, last year in our telehealth training that we do, this is helping providers learn how to use the technology, think about how to integrate this into their workflow. We delivered 43,000 telehealth specific. Most of this is online training. Some of it is done with our telehealth staff actually meeting virtually or in person with clinicians. But 43,000 training events last year across the system. That's a big number. Now we do have 380,000 employees in the VA, but many of them are not clinicians. Essentially 43,000 training sessions gets to most of our clinical staff. So I think part of this has been, number one, making the investment in supporting clinicians in adopting it. Every single medical center has a dedicated facility telehealth coordinator. Every one of our networks has somebody who is a VISN or network level. We have 18 networks that we manage the VA through. There is a network telehealth coordinator. That person wakes up every day and is thinking about, how do I help the clinical community better adopt telehealth within my network, and again at the facility level. And then every clinic, we have staff members who've been trained to be telehealth clinical technicians, to actually support the operations of telehealth in the clinics. If you go to a rural clinic, you'll walk in the front door and there's telehealth offered there. There's somebody there who's been trained to support the rest of the clinical staff in that venue. And I think that's one part of, I think, how we have been able to, by investing in making sure that there's somebody to help think about how to integrate this into the workflow, it's decreased some of the resistance that we could have seen. But I wouldn't say there's been no resistance. I think what has driven adoption thus far is when the telemedicine program solves a problem that the clinical community recognizes as a problem. Most providers in the VA, all providers in the VA, I think all providers in general, feel kind of terrible when a patient got up at 4 in the morning, drove 3 hours, got there 2 hours in advance because they wanted to find parking, dragged themselves into a visit, and they're there for 20 minutes or 30 minutes, and that's the entire experience. And there's something in providers that says, we could do this better, right? And when somebody comes along and says, you know what, we can figure out a way to make this work better, so for your patient, I think that drives adoption. What we often find is that we just have to get the provider to do that first visit, to experience what this is like, see the satisfaction that patients have. When we assess, we do surveys every year of patient satisfaction. Satisfaction for video telehealth across the enterprise, 92% for veterans. For store and forward telehealth, like a teledermatology visit, taking a photo of the dermatologic physician, sending it off and get back, is 93%. So very high levels of satisfaction, and I think providers are often motivated when they see that, particularly those who are working in rural areas where access can be really challenging.
What about, you mentioned access and capacity planning and quality. What about the evidence? So what are you seeing in terms of results?
Right.
Outcomes, costs, access. What kind of evidence can you share with the health systems here?
Sure. So I think I'll start with our sort of cost savings, because that often, I think, gets people's attention. It's hard for us to quantify how much money we save with telemedicine because the number can be rather large. A subset of our veteran population gets reimbursement for travel from home to a VA facility for their appointment. And so we could essentially recoup most of our investment in the telemedicine program simply through the savings that we have through travel dollars when somebody's able to either travel to a clinic closer to their home or increasingly receive that care in the home. Now, that's not something that really translates to health systems outside of the VA. But we have seen in our home telehealth program, so our remote monitoring program, last year we had 130,000 patients who received monitoring on a daily basis at home through our home telehealth program. And in that population, we had a 57% decrease in bed days of care and a 31% decrease in VA hospital admissions. So those are pretty significant outcomes.
Those are
for us.
RPM population, so you're monitoring
Right.
automatically, asynchronously monitoring.
Asynchronous automatic monitoring at home. In our telemental health population, those who received some of their mental health care through clinical video telehealth, acute psychiatric VA bed days of care were reduced 34%, and VA hospital admissions were reduced 31% in that population. So we are seeing real quality outcomes.
If anybody has a question, there's a question over here. Let's see, I'm not sure where the microphone went.
Hi, Steve Dean, Innova Health System. You've given some statistics on utilization. I'm curious if you put strategic thought into what percentage of your consults should be done virtually or could be done virtually.
I'll repeat the question real quickly. What percentage of consults could be or should be done virtually? If you looked at that.
Right. So this gets, it depends on what we mean by the word consult, right? So what percentage of visits let's use visits as opposed to consults. I think of consults more as a sort of a specialty consultation. Here's what I think. I think that every patient in the VA could benefit from having some portion of their care delivered virtually. In my mind, we should aim to have 100%. Now, there are some challenges. to get here. Not everyone has access to technology to engage with us virtually from home. There are some broadband issues in this country, particularly in parts of rural America, that we need to overcome. But if we're thinking about what should the vision of healthcare in the future look like, I think 100%, right now 13% of our patients receive some portion of their care through telehealth. I think 100% of our patients should be able to receive a portion of their care virtually. And I think that we should be, the opportunity is to be thoughtful about what that looks like. So I'll maybe use my own personal experience in clinic. I've increasingly, when I get secure messages, this is how do we start to integrate this all together as one kind of cohesive experience for patients. My nurse and I, when we get patients through secure messaging now, essentially it's a patient reaching out with a clinical concern. It comes into my clinical team, my nurse and I are working together. We now decide when that message comes in, the question is, can I resolve this by just answering the message? Can I resolve this by a video visit? And now about 20% of the time, I can resolve it with a video visit. Or does this person need to come in for a face-to-face visit? Now that's in primary care. There are other specialties where a higher percentage could be resolved, I think, through either video or electronically, virtually. So I would say 100% of patients should have the access and the capability to do this. And in any given specialty, we can do most care virtually. I'll give you an example. We run in this country, we have 11 teleprimary care hubs now that we run. If we use our teleprimary care hubs to fill clinical gaps that occur within the healthcare system. So we may lose a primary care provider, they leave the VA or they retire, somebody goes on maternity leave, something happens at one of our rural clinics, and we can't fill that gap right away. One of our teleprimary care providers will step in and completely manage that patient panel, 100% of that patient panel, remotely from the telehealth hub. But what we learned was you can't do all of primary care remotely. And I think this maybe gets a little bit to your question. So for primary care, you can't do it remotely. So the teleprimary care provider, once a quarter, every 3 months, goes and spends a month on site at the local clinic. We run clinics in Guam, American Samoa, a lot of sort of rather remote locations. The primary care in a portion of primary care in Guam is delivered from Boise, Idaho. The provider from Boise, Idaho travels out to Guam, does procedures, takes care of patients on that panel who don't feel comfortable with receiving care through telehealth, and fills those gaps. But with those 4 weeks of in-person care, we can deliver it all remotely.
Other questions? Here, Chris.
You'll probably have to correct me on the exact headline, but I remember the VA kind of breaking headlines around starting to offer care across state lines. So anyone in the VA can get care from any doctor, no matter what the state is. Do you have any things you can share about kind of the thinking behind that process, or anything that systems that are a little less unique in the mission than the VA can learn from your decision to do that?
Sure. So I mean, this is what we call our Anywhere to Anywhere telehealth initiative, a portion of our Anywhere to Anywhere telehealth initiative. And actually, there's some folks in this room who are very helpful and supportive in our moving forward in this direction. For a VA provider, a VA provider has to have a license in one of the 50 states, Puerto Rico or the District of Columbia, in order to practice care within the VA system. There was ambiguity within the law about whether that person could deliver care into a patient's home across state lines. So if you're on federal property, because we're a federal healthcare system, and you're in the VA facility, there was no ambiguity about licensure restrictions there. But as we were reaching out into patients' homes, there was a question about whether you needed to have a license in that state. The VA Mission Act was passed in it was signed into law, I think June 6th of this year. And there's a clause, Section 151 in that, which essentially says that VA providers who are practicing within the scope of their responsibilities within the VA can deliver care across state lines as long as they have a license and they're properly credentialed and we're managing and monitoring their quality, et cetera, within the VA system. We had also pursued a parallel regulation before we knew we were going to have a legislative solution to this issue. So that has been very helpful for us in that it does allow us to run hubs nationally where VA providers can very quickly be directed to deliver care in another part of the country. But I don't think, I think, and I know that doesn't extend to private sector healthcare systems, but I do think that we have learned some lessons. In general, our providers still are only delivering care in a limited number of locations, right? So it's not, with the exception of like our tele-ICU providers who are supporting facilities all across the country. But it does what it has done within the VA is it has increased confidence amongst our healthcare providers when we ask them to deliver telehealth. The fact that there is a sort of a marquee piece of legislation that says we expect you to do this has really, I think, galvanized a lot of VA providers, and I think that may be the more important lesson learned for private sector health systems is that when there is a clear and consistent message from leadership and from the top that this is part of how we do business, this is part of how we distinguish ourselves as a brand in the marketplace, that really does have an effect downstream on the front lines of care. And when there is the perception in the clinical community that leadership is sort of fighting for making this easier to do and breaking down barriers to delivering care and meeting patients' needs in a more convenient fashion, it really does, I think, change the culture.
Question back over here.
Hi, I do have a question, but I do need to make an observation because we were one of the groups that helped with that.
Yes.
And there are some caveats to it that are pretty important for the medical community. Mm-hmm. So I'm Sylvia Trujillo. I'm with the American Medical Association, and I'm on the digital medicine team. And we, I think, collectively have a request for the VA. So I'm formally making the request right here. We need data to help us show that care is being delivered in lower cost sites of care through virtual services in order to break through on the 1834M restrictions for the Medicare program. And we would love to have some of the data or work with the VA to aggregate and put together that data to submit to the Congressional Budget Office. And so to the extent that Krista Drobeck or some of the other advocates in the room could collaborate with you all in order to put that data together, it would be tremendously helpful. And my question to you is that doable and is that an option? But I do want to pivot back to the issue about licensure. I know it's on everyone's mind. We represent physicians, and licensure still remains very kludgy and problematic. And so the AMA very strongly supported and went to Congress and met with the Secretary, then Secretary Shulkin, in support of the licensure question for the VA. However, our physician membership made very clear the VA is unique. This applies to all of their employed physicians, who they have direct oversight and direct control of at all times. They have a shared EHR, they have a training program, and they have a tremendous amount of infrastructure, hardware, software to support their deployments, which is very unique in the American delivery system. Having said that, we do think that the lengthy time of licensure, even with the compact, is a problem, and we're looking to technology companies to collaborate with the Federation of State Medical Boards and the boards to deploy new technologies and modalities to streamline and increase the speed with which physicians can be licensed in multiple states. So the question back to the VA, can you help us?
Right.
So the data.
The data, right. Well, with the Mission Act, which officially helped us with sort of put the final punctuation on our licensure issue, also requires us to put together a rather comprehensive report to Congress by the end of this year. And part of that is forcing us to do some hard work in getting at some of the data that I think would be helpful. So we would be more than happy to share that as we get closer to having the data that might support your needs.
Krista, you had a question? Yes, here.
I'm going to ask you a question. First, my name is Robert Groves, and I'm the Chief Medical Officer for a company called Banner Aetna, which is just like it sounds. It's a joint venture between Banner and Aetna to try and align incentives. But my original, after 28 years of direct patient care, the original thing that I went to Banner to do was to roll out a tele-ICU. This back in 2006. We found the same thing. It requires patience of leadership and unrelenting support for the model. My question to you is going to be, what percentage of the potential of the current technology, I mean, the VA is one of the most progressive bodies out there leveraging these technologies. What percentage of the possible advantages have you accomplished to date, given current technology, and how are you trying to close that gap? One of the things that we discovered is, I was involved in early discussions with the VA on the tele-ICU program, and we had 4 principles. We said we want to respond immediately to requests for help from the bedside. We want to monitor for adverse trends, and that's the advantage of having those computerized systems. So it's in addition to the visual link, and intervene before those adverse trends become adverse outcomes. We want to increase reliability, dot the I's and cross the T's, all of those things that need to happen every day that get missed, and then finally measure what we do so we can continuously improve. And over 12 years, compared to Apache predicted, we've saved about $900 million just in Banner Health, and 15,000 lives and some 550,000 fewer hospital days. So I see those same principles being in the future applied to ambulatory space with wearables, with the Internet of Things. Is that possible? How far down that road are we, and how are you helping to close the gap?
So this is a hard question. So I think you're asking where, if we dream of the future where connected care or telemedicine, or whatever we want to call it, has reached its full maturity, where are we now? What percentage are we at? I think we, even though we're progressive, I would agree that we have been a leader in this space within the VA. I think we're probably still at, 8%, something along those lines. I mean, we're doing a lot, but there is so much more potential. When we start to think about, how do we leverage technology in a way for the healthcare team to be able to better support each other, to function more as a cohesive organization, improving quality, managing care better as a team, and then how do we really move care into people's lives, right? Healthcare, I think really our ability to be a healthcare system that exists in people's pocket, not with bad parking somewhere across town. We're nowhere close to realizing that, I think, anywhere in this country. And so I think we have a lot. I think this is why this topic excites me so much, because I think there's so much more room for us to mature as as a healthcare system at large in this country. And I would say the same would apply for the VA.
Are you being gated by the state of technology? Are there technology gaps, or is it really just, flooded with technical choices. Is what part of his question is asking about how much of available technology are you employing? So
Right.
it's wondering if there's a gap, technology gap, from vendors or solutions to help you do what you're trying to do, or if there is, what is that? And if not, then if the technology is fully available, then what are the challenges holding things up?
Right. Yeah, I think it's less about the technology, and I think it's more about the fact that implementing any of these programs is hard work that is essentially, it's massive culture change. It is culture change for patients. It is culture change for our healthcare teams. It is culture change for our reimbursement models. I mean, we in the VA, we are not immune to the challenges of reimbursement. We just call it workload, right? Well, the way within the VA, the way I am viewed as a valuable primary care provider is based on, VA's own unique version of RVUs. And they may not turn into billable, but it's all of these pieces of the ecosystem that are going to need to adjust to the fact that healthcare, I view this, healthcare moved from being predominantly delivered in inpatient facilities. We've already had the transition occur to the ambulatory space, and we're now in a transition period where increasingly healthcare is being delivered virtually. When we moved a lot of healthcare out of the inpatient environment, and many people here have an experience of thinking of when I started in the VA 17 years ago, you showed up and my senior attendings would tell the story about the patients who would show up with 3 suitcases to the emergency room because they were saying, I'm here for a month, I'm checking into the VA, right? I mean, it was, long inpatient hospitalizations. All of healthcare has moved to delivering care responsibly in the ambulatory environment. And I think we're really in a transition period. Those transitions take 20 plus years to occur because of all of the systems and cultures and things that have to change for that to happen. Young providers, when we hire them in the VA, their expectation is that they're going to be able to deliver care using technology because it's what they've grown up with, and we don't necessarily meet their expectations at this point in time. So anyway, long story is, I don't think it's technology. I don't think it's that we don't have the technologies. It's now figuring out how do you implement them in a way that makes sense within the overall healthcare system. What is the evidence behind delivering care virtually? What should best be delivered that way? What shouldn't be?
Let's see if we can squeeze in 2 more questions before we're out of time. Question in the back. And then Krista.
My question is based on the adoption of technology from some of your more elderly veterans, because a lot of what we're talking about is keeping care at home. It requires them to be somewhat savvy with the tablet, with the phone, with their computer, and some of them aren't, particularly in rural areas. What are you doing to help with that adoption and education for the technology so some of those more elderly veterans can utilize the technology?
Sure. So 40% of I think I mentioned 47% of our patients are 65 years of age and older within the VA healthcare system. Many of our patients who are benefiting from connected care are older. If we look, I just saw numbers the other day about the numbers of users of our portal. I think I actually brought this, just kind of, I thought it was interesting. Of my Healthy Vet registrants on our portal, we have over 350,000 who are 85 years and older. Those are active users of our health portal. Now, so those numbers are pretty striking. How do we do that? We do that because in the atrium of every VA medical center and in our clinic, there is somebody who is there to help patients when they come for their visit learn how to use our technologies. And so we call these are My Healthy Vet or Connected Care coordinators. They're helping with some of the simpler things. With regard to technology in the home, Again, it's about training. It's about sometimes doing a home visit. But our experience has been, if you get somebody set up, and if you've made the right technology choices and you've thought about it, it's not for everyone. But most patients figure it out. The other thing is that most patients who are 85 years or older have somebody in their life who is technology savvy, who is supporting their care, and who really welcomes the introduction of technology, particularly if that technology helps them connect better. For example, our VA Video Connect technology. We can now deliver video visits into the home and have the patient's daughter, who may be in another city, join that visit, and we can have that visit together. So we can have the patient at home, daughter 3 cities away, provider who knows where, and have a very productive discussion. Those kind of, when there's that value realized by the family, people figure out a way to learn to use the technology.
So before Krista gives us the hook, let's, we're out of time. Could you sum up for the private systems who are here, any lessons or advice you would have for them from the journey that you've been on?
I think, well, first of all, it's got to be a priority that you want to move in this direction. Second of all, it's a long journey sorting out the issues. We've sort of highlighted both of those issues. But I guess the other thing that would be another lesson learned is, and I think Chris's talk from Stanford really highlighted this. Find specific use cases where people are frustrated, and then apply the technology to that use case. So I thought the example of the second opinion program that Chris shared was tremendous, right? Here was a place where providers were not covered by their malpractice insurance, where there was value that could be realized for the brand by delivering second opinions, and where there just needed somebody to come alongside and have some discipline and thinking about how to apply some technology there, maybe partner with others. It sounds like you partnered with somebody outside, and to solve a problem. I think that's how you start to build a workforce that believes that this could make a difference and can then move the whole system over time. Don't try to boil the ocean. Solve individual problems. And then the other thing is, the other huge lesson learned is early engagement of the clinical leadership is absolutely critical, right? The only reason we have telemedicine programs in 50+ clinical specialties is because the clinical leads for each of those specialties was in at the front door and thinking about what should this look like in cardiology? What should this look like in pulmonology? What should this look like in ICU care, et cetera?
Well, Dr. Evans, thank you for your time to share the experience here, for your leadership in making telehealth really healthcare for our veterans, and giving us all examples of what it looks like when it's deployed at scale and it's working. Again, thank you very much.
Thank you.
Please.
Boy, Dr. Evans really set us up perfectly for our next session by saying that one of the most important things is engagement by your clinicians, because that's exactly the topic that Dr. Lyle Berkowitz is going to tackle. Is he in here? Where is he? Oh, there he is. Okay. Lyle Berkowitz is a primary care physician, a digital healthcare innovator, and a healthcare tech entrepreneur. And he serves as MD Live's Chief Medical Officer and Executive Vice President, Product Strategy, and he's the president of the MD Live Medical Group. For much of the last 20 years, Dr. Berkowitz has helped lead IT and innovation at Northwestern Medicine in Chicago. It's a top 15 healthcare system with annual revenue of over $5 billion. He has additionally helped start and manage several healthcare IT companies and currently sits on the board of at least 3 big health IT companies. He graduated with biomedical engineering degree from the University of Pennsylvania and he's actually an associate professor of clinical medicine at the Feinberg School of Medicine at Northwestern, and has fellowships at the American College of Physicians and HIMSS. So please join me in welcoming Lyle Berkowitz.
Okay. Thanks, Krista. Can you do me a favor? I sent you some slides this morning, if you're able to send to the group over here, but that's okay. I can talk without slides as well. And they even hooked me up so I can walk around because I just have to do that. So I am an internal medicine primary care physician, spent 25 years at Northwestern Medicine practicing primary care along with escalating physician executive roles. Was 20 years ago a young doctor as the EHRs were rolling out in rooms about this size with as many people who were all sitting around thinking, I bet we're so close to having EMRs go throughout the nation. We were a little maybe forward thinking, but the same idea here and the same sort of concept, and just to take a moment and appreciate where we are in healthcare. It's not many times in someone's career, in any industry, that you can be involved in the middle of something that's truly so disruptive, so innovative, and doesn't have the rules of the road. So we all get to sort of create it. And thank you, Krista, for helping us create those rules and get them passed at least, because it's going to be really important for us. And learning at places like this are really important to share those. So I am here, I am now with MD Live, one of the nation's sort of largest online medical groups and technology and telehealth companies. But I'm going to talk to you about something that's been really a passion of mine for many years, and that is understanding physicians and getting physician adoption of things that they may not want to do initially, but when you help understand them, help them understand what's going on, you want them to not just accept but embrace changes in healthcare, because change is hard. The year 1846 is always one of my favorite years in healthcare. Two major innovations were brought to the forefront, both published, both widely spread and talked about throughout the world. Both had profound potential impact on healthcare. One, and both decreased, pain and illness, cut mortality, morbidity, etc. One was widely adopted within months, spread throughout the world. Everybody did it. The other one, to this day, we struggle with, even though it may be equally important in its impact on quality. One made life easier for doctors. One made life a little harder for doctors. Anesthesia and hand washing. You can probably guess which is which. Can you imagine being a surgeon before anesthesia? That must have been pretty difficult. Pretty easy to get people to accept anesthesia. You had someone else who would do it. Someone would be out, versus hand washing, like they had to use borax, something. I mean, it must have been painful and time consuming, and they weren't convinced of its benefits. And in the same way, when we started working with electronic medical records, we had to convince doctors this is something that is good and can help you. We may have overplayed it, but they adopted it, and there are benefits obviously to EMRs, and I spend a lot of my career in that. But I've also spent an equal amount of my career in some ways in telehealth. I was emailing with my patients in the 1990s. It's because I grew up in the era where there was email, and it made sense for me to do that with my patients, particularly as I was doing some management work and wasn't always in the office. And then, secure messaging, iPhone, whatever it took, I was always happy to do virtual care with my patients, particularly because I wasn't always in the office since I was traveling around. And I tried to implement it multiple times at Northwestern and struggled, mainly because of the reasons you'd think. In the fee-for-service world, it just made much more sense economically to tell the patient to come in than to do anything virtually. Technically, it was possible, although I do remember in the 1990s, when capitation was coming to Chicago, and we had a significant amount of HMO patients, all of a sudden virtual care was fine. All of a sudden everybody was happily doing phone consults, and no doctors were complaining. If you called and there was something they could handle without you coming in, that was great, because we were getting full capitation on a number of patients. and bringing them in the office didn't offer any new RVUs, any financial gain. And so we would spend the time on the phone to take care of it. So interestingly, that was fine. But then we got rid of capitation, and coming into the office made more sense. So, there are no, similar to electronic medical records, there are no benefits of these systems without some level of adoption. And there are multiple levels of adoption. We've heard about patient adoption, if they're older, don't have technology, et cetera. We've heard about physician adoption to use the system, great talk from the VA and from Chris at Stanford. And I'm going to talk about a little different type of adoption, and that is adoption of the physicians who are in an organization, in a health system, and how do you get them to embrace the use of a external or internal partner? The fact that you tell them, hey guys, you're not going to see every patient. You're not going to see all your patients anymore. The demand is too high. What if we have someone else, someone that see those patients, so that you can see the patients who need to come in? So in fact, we'll particularly take what I call the routine repeatable type of events, those patients who have those minor, mildly urgent type of issues, and move them out of your office. Are you willing to let a partner do that? And in so doing, you can take care of the patients who need to come in. And if you can do that, we can start scaling, start making everyone work to the top of their license, especially if we get a partner who can do that particular thing better, faster, and cheaper than you. And as you can imagine, doctors' initial reaction is no thanks. How many health systems are here? I know I had a bunch talking to, a fair amount. I talked to somebody last night. I was a little worried. I wasn't sure if this would resonate, if this talk was that interesting to folks, but at least talking to the folks last night, I heard, yeah, we're sort of interested in this. So I hear a couple things. Number one is, you're stealing my patients. These are my patients. I don't want anyone else to see them. Number two, I like having easy patients. It breaks up my day. It makes my life easier. Number three, it's easy money. Those are quick visits. Get them in and out, and I can just fit them in anytime. And I get it. I've been in that position. I've seen that. It's doctor's life. And in fact, 15, 20 years ago, is probably certainly more true. You had, you looked at your schedule and, at least once an hour, you're going to have one of these patients or a couple of them. It was a significant part of your day. And we remember that in our minds. And we think about that when you come and say, hey, what if all of your sinus infection, UTIs, rashes, and overall mild stuff didn't come into your office? And the doctors are like, no, I need those. Well, the truth is, do an analysis. They probably lost them already. I did the analysis at Northwestern, where it had once been close to a quarter of visits, was down to 3 years ago when I did under 8%, probably under 5% now. We lost them. Now, in our case, we opened up urgent care centers, and so we lost them to our own urgent care centers, but my gosh, we also lost them to all. There's an urgent care center every block. I'm in a neighborhood in Chicago called Bucktown. That's where my office was. On either side of me, within a few blocks, there was a retail clinic, 2 urgent care centers. My patients had every option in the world, including my own urgent care centers. If they need to come in, they would just go where they wanted to go. And similar to what has been applied by others today, and a well-established UPMC study that I talked about with the guys at UPMC a while ago, patients get that they may not need to see their doctor for these minor things. They want to see their doctor if it's important, but they actually not only understand that these things are a bit of a commodity, these minor issues, but they don't want to bother their doctor. Their doctor's important. Their doctor's smart. They don't need to deal with a minor thing. And yet, many organizations, particularly like academic medical centers, sometimes get in the trap of feeling only our doctors can take care of our patients. And I get it, brand is important, et cetera. And yet, they shoot themselves in the foot, because by doing that, if they do that, they're clogging up their own resources. They're highly paid, very smart resources to take care of things that should be at a much lower level. And Not only that, but it's not very scalable. Every time they see one of these, even if they do it virtually, it still takes up a block of time. And in fact, when you're sort of just seeing a couple virtual visits a day scattered throughout, you're probably taking up that same 15-minute visit. I'm starting to say now we have to undemocratize healthcare. Not everyone should have a 15-minute visit. A 22-year-old with a sinus infection, a 72-year-old with CHF are different entities, but in our system, they each get a 15-minute visit. That's not right. That's not how any other industry would work. And by the way, that 22-year-old does not want to come in. And if you don't offer him a better option, he'll find it. And that's what's happening. And it's going to happen for patients who are already in your system and happy with you. But there's also 40% of America who doesn't have a primary care doctor. And they're not going to get one. They don't have one because of geography, resources, et cetera. The 60% who have a primary care doctor, they don't have particularly easy access to get to a doctor all the time anyway. I still take visits on the platform. I still like being a doctor. My first visit was a woman who was doing a video visit with, and she had her phone, and we connected, and I could tell she was driving. I said, "Ma'am, could you pull over?" She said, "Sure. I didn't think you'd call back so quickly." So now she's on the side of the road, and she shows me she's got horrible sunburn on her legs. Took care of it, gave her some burn cream, told her what to watch for in terms of infection. And I said, "Do you have a primary care doctor?" She said, "Yes, I do. He's at Northwestern." I'm like, "Oh, really? I might know him." I said, "How come you didn't go there today? I'm curious." And she said, "Well, I have to work. I can't just take off work. Many of us, I'm sure, can take off work. Not everyone can." And she said, "It's an hour away. I have to make an appointment. It takes a long time. I just don't have time to do it. I love my doctor. I see him once a year for my checkup. If there's anything really serious, I'll see him. But today, I just didn't have time to even think about that. This is an amazing service." And that's what we see over and over again. And there's something else that was, I think, mentioned by the doctor from the VA here about appreciation. Many of our doctors who join us find that that's one of the biggest benefits. Flexibility, of course, but appreciation. Because when you don't have to have a patient who spent 2 hours to get to you, waited in an office with sick people, and then you saw them for 10, 20 minutes, they're like, "Hey, oh, thank you." But when you have a patient who, like 5 minutes after they press a button, they have you on the phone and you take care of things, they're like, "Oh my God, thank you. That was amazing. This is like Star Trek," right? I mean, that, for doctors, that's just gold. Just give it to us over and over again. So we love that. So from the doctor's perspective, in today's perspective, like I said, I want to focus on is what are the things you can start thinking about and do for these patients, these providers who are scared of having a partner. How do you get them not to just accept, but to embrace having a partner? So I'll call it the 3 M's. The 3 M's: metrics, money, and emotion. I couldn't think of it. And then it did hit me, there may be mission, but the same idea, something about professionalism. And the idea is metrics are important to doctors. We're scientists. We like seeing the numbers. And if you can show them the numbers, they often understand and it clicks. So again, I don't have my slides here, but I have 3 reports I suggest you do. Report number 1, access report. Whether it's established or new patients, you probably know this already, but what is your average same-day access for an urgent issue? Someone calls up and says, "I need to get in." How quickly can they get in with a specific doctor or any doctor, perhaps? You could also, and same thing, I need to get in for an annual exam. And you can do immediate, and you can also do the famous, the third next appointment. I'm sure most of you know this stuff already. Most primary care offices will have this information, but it's an important one to share with the doctors, particularly an individual doctor. When he says, "Oh, I can always fit someone in," and you show him, "No, you can't." And if someone asks, "I'll fit them in," but they don't ask. You're full. You can't get them in. And by the way, if you do fit in your patient with that easy thing, that means someone else, another one of your patients, can't get in and probably is going to the ER. Number 2, leakage report. What percent, again, of these, this is the report I did, of minor urgent issues. Just sinusitis, URIs, bronchitis, UTIs, maybe rash. You can look up those ICD-10 codes and look what % of your primary care doctor's visits fall into those codes. If it's like what I did, you'll find a sharp decrease over the past 10 to 15 years. And it's probably a much smaller part of what the doctor's life is these days. And again, showing them that this happens already helps them understand they've lost this. Don't complain that's getting stolen, it's been lost. And the next step is, wouldn't you rather lose it to a partner? Number 3, the burnout report. And this is the average appointment time versus RVUs. The truth is your average appointment times probably have not changed. I doubt many of you have just said, oh, we're going to go from 15-minute to 30-minute appointments. But assuming your average appointment times are the same, what are your, how many RVUs per appointment or per hour or per day are your doctors seeing? The likely answer is your RVUs have gone up significantly because the complexity of care has gone up significantly because the simple stuff is out, people are getting older, there's more to do, et cetera. And when you talk about the burnout problem, I think the issue is much more that we're trying to get doctors to see much more complex stuff in the same amount of time when they used to have a lot more simple stuff in there. It's an issue that I don't have an easy answer for offhand, except to say as a health system, you have to acknowledge that and start saying maybe we need to change how we look at primary care. In fact, primary care really should be online, as we heard. Secondary care is in the office. The JAMA article earlier this year by Thomas Lee, I liked it. The office visit is Plan B. The office visit is Plan B. The office visit is secondary care. There's tertiary care, specialist, quaternary care, but primary care, online first. Imagine that. By the way, others who didn't imagine that include Blockbuster, and banking, Walmart, many other industries who didn't understand that patients love going online. People love going online. The fourth is HEDIS reports. How are your HEDIS metrics in outpatient areas? Things like antibiotic usage, statin usage, preventive care screening for the entire population, for the panel. When's the last time you really looked at those and said, how are we doing in a panel-wise? How can virtual care help with that? So those are a couple of the things that you can look at on the metric side. On the money side, and this is an important one for doctors, right? We have to think about what can we do to make sure everything's aligned, because incentives matter. I always like this line, incentives matter whether you think they do or not. So one, you're probably, hopefully, just in terms of getting general adoption, you're paying your virtualists something good or acknowledging that that is an equal type of pay. But what we're talking about now is how do you get the doctors who are not doing virtual care? How do you get them incentivized? One, what if you gave them bonuses based on things that are aligned with using a virtual care partner? Things like their total panel size, quality metrics, ER admissions. So if you're aligning them with things that you want and that a partner can help with, then they're more apt to say, oh, you know what, if that patient can't come in, have them see my partner, my online partner. But by the way, whether it's your docs, whether you've designated a doctor or nurse practitioner, whether you've outsourced that, get them comfortable with doing that. Most docs, by the way, are comfortable saying, well, go to the ER if it's too sick, go to the urgent care. So this is just another form of that. And second, what if you could buy into the system, give them a small piece of RVU for every outside chart that they review with your virtual partner? So now you're acknowledging, giving them credit for the fact that they're reviewing it, maybe make them give a quality score on it. But now they're bought in, they're saying, okay, if I send 10 patients a day to the virtual care clinic, I can see the ones who really need to get seen today, and by the way, I'll still get a little credit for those virtual care. Try and be creative. Think about how you can align it so you get to the point where doctors go, okay, this makes sense. Rethink schedules. Like I said, if you're asking doctors to see more and more complex patients, rethink how their schedule is set up. Are you going to expand their schedules, pay them more per RVU? Again, this is something that we have to deal with at multiple levels, but it is going to help prevent burnout. And what you're probably all finding is your primary care doctors are cutting down significantly their schedules. Most places I talk to, very few people have 1.0 RVU or 1.0 FTEs anymore. a lot of 60 and 70% doctors. Highlight the fact that cross coverage, evenings, weekends, even during the day, is going to make their life easier. That you'll get decreased leakage, so you're not losing the patients, and that from a system perspective, you're benefiting from decreasing burnout, and of course, making sure that patients are getting the care they need when they need it, and keeping the loyalty of the patients. Finally, emotion. Making sure you understand your physicians, what they need, talking to them obviously, but understand what really bothers them. How might they embrace more partnership in this situation, and change the language from this is not your competition, these are your partners. These are the same way you should think of other partners in the health system. You need executive support and physician champion. Consider how you put together a physician advisory panel on telehealth that can provide input and spread the word. Public recognition to ensure that two things. One, good stories come out about how a patient loves getting telehealth, often through the partner. Two, how about a story about a physician who, by using this partnership, was able to actually get out at the end of the day at 5 o'clock, not actually get to spend time with his family, or go home and not have to get online at 10 o'clock at night. Analogies also help when you're trying to evoke some emotion. Remind them about the hospitalist movement. You resisted that, remember? You said the same things. Hospitalists, they're taking over the stuff I need to do. I need to be in the hospital. Only I can see my patient. But they recognize eventually those guys actually did better. Virtualists, who are doing this, in our group, we have people who are 40 hours a week doing this. They're really good at it. They're the virtualists. There's the new specialty. Their website manner, is awesome because they're doing it all the time. Just like hospitalists. And just like hospitalists, it became a partnership. You take care of those guys over here, I'll take care of the guys in the office. EMR rollouts, same idea. What do we learn from the EMR rollouts? We had much more, we had the advisory panels, we had a support staff, we thought through reimbursement, et cetera. There's a lot to learn from that analogy. Outside of healthcare, banking, the top of license analogy. When you have a doctor doing sinus infections, that's like you going to the bank and asking to cash a $20 bill and getting the vice president of the bank. They don't do that, right? They have tellers, and then they have ATMs, and now it's on your phone. Blockbuster and Netflix, Uber and cab drivers. What happened there? Understanding what problem you're solving. And understanding in what's going on in the industry and the world at large, is people are looking for more convenient, easier ways to do things. And travel agencies, all these things. When people realize the problem they're trying to solve is not, the Blockbuster thought the problem they were trying to solve was people they need to touch video and DVDs, and they need to talk to our staff. And Netflix realized the problem they have is they just want to get media as quickly as possible. And where are you, healthcare systems, when you're sitting there? So, no, people love to come into the office. They don't. They don't want. They love their doctors. They don't like having to go in and see their doctors if they don't have to. When they need to, they want to get in. So in the same way, where are you seeing? Are you going to be Blockbuster to Netflix out of business? I don't think the big healthcare systems are. You're still going to have your offices. They'll still be busy, but it may change. You maybe have your internists may become complexologists. The urgent care centers probably won't be in as need or maybe shifted to something else. But studies are showing more and more care will be online. People want it. It's easy to do. It's cheaper. It becomes scalable. We're using technology. We're automating care. Because we do things at scale, thousands of virtual visits every day. We can start to automate stuff, use AI, use asynchronous. The problem we're solving is not how do I connect a patient and doctor for a video visit. That's cool. That's good. There's benefits there. We do that. But the problem we're solving is how do we take care of a patient who has a medical issue, whether that's video, phone, asynchronous, automation. when you look at from that perspective, we're able to do those things at scale, and we're not trying to solve the most complex things. This is really talking about the basics of primary care. That bottom 50 or 75% of the pyramid that has routine, repeatable stuff that can and should be done online. So as you get your doctors to understand this, you gather those stories, you figure out how to make their life easier by bringing this in, and make the incentives aligned for them, and then they'll start coming to you. So I just wanted to share a couple of those thoughts. I know, like I said, the last night dinner had a number of discussions on this. So I'll end there and see do we have any time for Q&A? Okay, I can take one Q&A if anyone has questions on this type of provider adoption. We had so many questions last night. I know. That did make it easier. Anyone here have I'm curious, has anyone done anything financially to reward your doctors for sending folks to a virtual care partner of some sort, even if that is within your own organization, et cetera? Have anyone figured out a way to align those incentives so they don't feel like they're losing a visit? Chris, I'm counting on you. Yeah.
We blocked, one of our primary care clinics blocked out 10% of their schedule and said that 10% of your schedule had to be virtual. One of the issues then was that, like I had kind of highlighted, is a lot of that was done through the phone and inconsistently documented. And actually there was, one of the things we had to control for was, I think the visit quality was just as good, but if you take the call on your way home, Congresswoman Eshoo really astutely stated it takes 2 hours to go up the 101 where we're from. So we have doctors that'll conduct a call from the car. So we blocked the schedule, but now we're trying to figure out how to structure that in a way where we understand the types of visits and the diagnosis and the value to the patient and the right modality in there. So I think that's kind of an incentive. And especially for a non-salary or for a non-RVU based physician that's salaried, that is effectively an incentive.
Yeah. What I'd add is my last thoughts in terms of next steps at your organization. My advice is pick one clinic that you can start with and just do everything you can to make them successful. Look at their numbers. Figure out a reimbursement mechanism for them. If you can make that one clinic successful in a place where you've got a doctor who's like, this is great, yes, please, take these folks off my plate so I can focus on the ones who really need to come in. And by the way, I get reimbursed. If you can do that and show that works, you'll start getting, you'll learn, you'll make mistakes, you'll learn, et cetera, in a small environment, and then it'll be so much easier to spread. And by the way, this is very different than the specialty space where I think what you guys are doing is great. This is at the primary care space where you're really looking to sort of outsource some of this and work with a partner. Again, whether that means a group of your own doctors who are dedicated to that, outsourcing to external partner, et cetera, there are a couple of options. But pick one or two clinics that you can really experiment at and think about how you can make them so wildly successful that everybody starts looking at them and say, I want that. How come you didn't start with me? If you do that, you'll start getting some wildfire adoption and be ahead of the curve. Okay, thanks again. Thanks, Krista.
Okay, we're going to have our last session with Mike Baird and Shauna Coyne. And then for those of you who want to stay and talk any more in depth about any of the new regulations and rules, I'll stay behind and we can have that conversation. I want to welcome Mike Baird to the stage. He's the president of American Well, which acquired Avizia in 2018. Mike has been with the Alliance from the beginning and a big believer in us, so I'm really appreciative of everything he's done for this organization. He was the founder of Avizia in 2013, and the goal was to improve access to telehealth by eliminating barriers to adoption and driving a holistic and all-encompassing product. So he led a team of innovators to create the enterprise telehealth platform, which then got sold to American Well. Prior to that, he held senior positions in strategy, marketing, and product development at Cisco, McKinsey, Dell, Tandberg, We get the idea, Mike. You're a smart guy. He has a bachelor's degree from Brigham Young and an MBA from Northwestern University. Oh, hey, Northwestern follows Northwestern. But I went to Michigan, so that's no good. Thanks. Please help me welcome Mike.
So you guys have the slides, right? We'll get those up here. So I just really appreciate you all being here today. It's a busy day. You've got lots of places to be, and sitting around to talk about policy for a whole day can sometimes be a long event. At American Well, what's that? It has been fantastic. It has been fantastic, and the best part about it is seeing so many health systems together to share ideas. So at American Well, we're fortunate in that we work with over 55 payers. We're in 7,000 employers. We're in 2,000 hospitals. We're in a lot of places doing telehealth. And of all those places, and we have many great customers here today, so this is not meant to be disparaging of any of them, one of the people that we love to watch is New York Presbyterian. And the reason for that, and I loved your presentation earlier, Chris, so thank you for sharing some data. We're going to share a little bit of that today. One of the reasons why we love working with New York Presbyterian is they've actually bucked the trend. Usually systems find that their urgent care volume is substantially higher than their critical care, as was shared by Chris. One thing that's unique about New York Presbyterian is it's actually the reverse there. They've managed to do a very high volume of consults spanning across the continuum of care. And ironically, we actually find that some of their highest volume services come from acute care or critical care service lines in the hospital. And we think that's a really fantastic perspective to share. They're doing telehealth across over 15 different use cases and service lines today. Shauna will talk more about that. So I'm going to have Shauna come up. We're going to share some slides. As she comes up, let me introduce Shauna. So she's the Director of Innovation at New York Presbyterian. She oversees operations and implementation of their enterprise telehealth platform. They're all about using the latest technology to improve care. She was one of the original founders of their innovation center. I've worked with her for a number of years now, and she's been at NYP for over 7 years. She's from Ireland, which makes her extra interesting. Graduated from the University of College Cork, Ireland, with an honors degree in business information systems. So she loves to travel, and she's a really fascinating person. So feel free to ask her questions. One of the things that we appreciate about NYP is they love to share. And that's where these efforts are so important. One of the things I love about healthcare is we're all here for the same reason, to improve patient outcomes, and we're going to talk about that today. So Shauna, if you wouldn't mind, let's go ahead, and hopefully that clicker will work. We can test it here. She's going to share a couple of quick notes, and then we'll proceed with a couple more questions, and we'll leave it open to Q&A afterwards.
Great. Thank you, Mike. Thanks for the introduction. And Krista, thank you for having us. I'm very fortunate to be part of this event. I think it's been a great day listening to everyone. Chris, your presentation was great, and I can really resonate in what you're doing in Stanford. But what was great about today is that the whole day was talking about barriers that all of us are facing, whereas normally when we're all at conferences, it's kind of talking about all great things that everyone is doing, and I don't want to spend too much time talking about that, but actually getting down to the discussion of, what works and what doesn't, and where we're struggling as an organization. So New York Presbyterian launched a telehealth program just over 2.5 years ago. We called that program NYP On Demand. Basically, when we were figuring out which way or which area should we be focusing in on telehealth, we decided to develop a whole suite of services. And this kind of ranges from our direct-to-consumer. We have a second opinions program. We have urgent care program, and bridging that gap into the continuum of care and bringing the patients in our system, whether it's fast-tracking them through our emergency department, whether it's doing specialty consults and peer-to-peer visits. New York Presbyterian, we have 10 different hospitals across New York and the boroughs, and we're affiliated with Cornell and Columbia University, so most of our physicians are located in our 2 main hub campuses. We also launched a mobile stroke unit, so we have 3 different ambulances throughout the city. By partnering with FDNY, we're able to treat patients in real time and administer TPA as needed. And then just recently, we launched a remote patient monitoring program by working with Philips. So I can go into a couple of more details around that program. But we're fortunate enough that our executive leadership and our CEO is very passionate about telemedicine, and they made this a priority across the organization. We are focusing in on speed and scale. And we are trying to do that across opening up access channels. Access is a huge problem for New York Presbyterian. It normally takes 3 months to even get a referral into one of our specialists. So that's really kind of the drive our CEO was giving us, was to set the bar and try and open up the access channels, but also giving us a pretty high target of getting to 100,000 visits by the end of this year. And I love, Chris, how you brought up around what defines a telehealth visit. Unfortunately for us, our CEO defined that as a virtual connection. So we're just over this 70,000 mark. As as Mike mentioned, most of this volume is coming from our acute and inpatient setting. We have over 50 telehealth programs across our 10 hospitals, and we have approximately 700 providers on our platform. And just focusing in on access for a minute, I did mention our Second Opinions program. Before it would take 3 months to even get a referral. Now we're able to turn around a second opinion in 48 hours. We also partnered with a third-party company who's allowing us to do that in 46 states. We launched an urgent care program just around 2 years ago now, where we're using our own board-certified ED doctors. We have, on average, it's around under 5 minutes to connect to one of our doctors. And we also launched kiosks around New York and Duane and Reed locations. What's next? For our telepsychiatry program, around the 10 hospitals, before it would take around 28 to 48 hours to see a psychiatrist if a patient came into our facility. Now using telehealth and using our inpatient services, we're able to connect that patient to a psychiatrist in under an hour. And I previously mentioned our mobile stroke units and the ability to treat patients in real time. I did hear today as well as a common theme that, stroke patients, they're losing 2 million brain cells a minute. So every minute that we're bringing that patient to our hospital, instead of treating them in real time through the ambulance, we're saving thousands and millions of brain cells. And this is just a landscape of our Second Opinions program and how we've conducted Second Opinions visits. Some of the interesting stats out of our Second Opinions was that 60% of these Second Opinions end up in change of diagnoses, and 24% have actually changed in treatment plans. So before, most of these patients wouldn't even be able to get into our hospital network. So now, by leveraging the technology and the third-party vendors that are out there, we're able to broaden our reach. I just wanted to quickly mention our partnership with Walgreens and also highlight Ron here, one of our patients. So the advisory board, they had a paper out that 78% of patients would actually change their primary care provider to a primary care provider that offers virtual visits. So this is Ron. Ron has not seen his primary care provider in 9 years. He was walking to work one morning and he felt a shortness of breath. So he's walking past one of our Duane and Reed stores down on Wall Street, and he saw a sign for a kiosk to connect with an emergency doctor. So he went in, he was connected with their doctor immediately, and he was advised to go straight to our ED, which was luckily enough a couple of blocks away, and he is diagnosed with heart failure. Chronic heart failure. So we believe, and our ED doctors believe, that offering this access to our patients where they didn't know this was available to them is really saving lives. I mentioned the Walgreens. I also mentioned Philips and remote patient monitoring. So even for the likes of Ron, who came in, he was in an acute care setting, came into our hospital, and focusing on the continuum of care. How do we continue to care for Ron when he leaves our hospital? So with remote patient monitoring, we're able to diagnose and treat chronic heart failure patients at home. We launched a diabetes program and postpartum hypertension programs as well. So we're still kind of in the discovery phase, but we really do feel that continuing the care of our patients is where we need to kind of focus our effort. And one of our other partnerships, and this was kind of a collaboration between American Well and ZocDoc, is integrating our on-demand services through the ZocDoc app at New York. ZocDoc, I think they're scheduling over 2 million appointments a year. So if you're searching in the New York area for a primary care doctor, urgent care doctor, the first option you're going to see on your search list is our NYP on-demand option. I did mention about our mobile stroke unit, so I'm not going to go into too much details. But we have one neurologist that is remote, and he is monitoring the fleet of ambulances that go around the city. So although it's not, we are putting a lot of resources and funding into this, we still have to kind of take a step back and realize how we can actually leverage our specialists in one area instead of having each one on the ambulance. One other thing I wanted to highlight, and we mentioned this about most of our volume is kind of bringing traffic through the ED and speeding up the efficiencies. We do virtual express care. So for low acuity patients that come into our ED, they're directed into a virtual room. They see one of our ED doctors that's remote, and they're discharged straight from the room. We also do a lot of medical screening exams, so we're speeding up the process of patients coming in through our EDs and reducing the time to provider and the door to discharge times. And apart from the challenges that we were talking about today, reimbursement and policies, price point has been a big challenge of ours for urgent care. Because they are our board certified ED doctors, our universities didn't want to jeopardize their rates. So we are charging a higher cost, nearly double the market price actually. And our scheduling standardization to keep the continuum of care. We don't have any schedule standardization. So that's because we have the 2 schools and we have 10 hospitals. We have 9 different EMRs. So doing that has proven a challenge for us. It's something that we're continuing to work through. Also, our dedicated physician time. Some of our best practices is really when physicians block off times to see their patients. This is more for the follow-up, the follow-up visits. Because of reimbursement has been an issue for these follow-up visits, it's been kind of hard incentivizing these physicians to do that. We have kind of thought of ways of reimbursing them for visits that would not have been reimbursed before and setting blocks of funds for them. But that's another barrier that we're facing as well. So I'm going to stop there. I feel like I went on a bit too long.
That was fantastic.
Thanks. That's okay.
So thank you for that overview. And as you can see, they're doing some fantastic things. One of the things that stood out to me, Shauna, when you started, you talked about how you had a leader that was pushing you to get, I think, 100,000 consults this year. I think it's 250,000 next year. I've noticed that, when we've talked to other successful programs like Intermountain, who's here today, Cleveland Clinic, and others, they had a similar thing. How important has that been for you guys in driving it? And were there any other things that really helped telehealth become such a priority?
I think you do need to have this as a priority, and it has to be set from the CEO and the executive leadership. Communication has to be in place because even though our CEO is telling us that we're going to get to 250,000 next year, we're going to get to that 20% conversion rate, so that telehealth is just going to be health, and it's the way we are going to take care of our patients. Having that communication across all practices, across Cornell University, Columbia University, that is really, really key, and it doesn't happen overnight. So it's continuing that message that we're all on this journey together.
And it sounds like it's helped break down some barriers. When you talked about all the different programs that you're doing, Are there any unique ones that surprised you that telehealth worked quite well for? We talk about stroke a lot, we talk about urgent care, but what are some of the other ones that you were surprised worked so well?
So as we're looking at kind of expanding the care team, so it's not just having these episodic telehealth visits, we also figured out that we need to make sure that the providers are working at the top of their license. And I know someone mentioned today, what are the pain points of these providers and how can technology help them? Med reconciliation was a huge one. So now we actually have pharmacists that are sitting remote, and they're doing all the virtual med reconciliations for patients that come through our hospital. So that's taking the burden away from the provider, but it's also improving our quality. So before we had pharmacists doing that med rec virtually, we had approximately 70% discrepancies in our med recs because providers just don't have the time to do that. So that was one of the use cases that kind of only came to light, I'd say probably a couple of months ago, but it's something that really took off because providers want this. We got their buy-in, and then we had the pharmacists to staff.
So many of us have been used to the concept that telehealth is for rural areas. You guys are in Manhattan, the exact opposite of rural. Anything about that makes telehealth successful or why it's so important in such an urban area?
I actually think it makes it quite difficult because a lot of the reimbursement, we are just focusing on rural areas. Even for our urban areas, broadband is an issue I've heard a lot in rural, but in urban, and as we're looking at taking care of underserved populations, especially around the Washington Heights area and the ACNs, that people don't have access to data. It's not the Wi-Fi that's an issue, is that they don't have access to smartphone, they don't have access to going to a primary care doctor. So it's trying to figure out those ways as well of how do we still take care of those patients even though it's not as easy for them. Even for example, just a kind of a barrier that we had in an urban setting in Manhattan, what we've seen with our remote patient monitoring program. So we were trying to figure out how do we get the devices to the patient's home. And the first thing that will come to mind is we'll just give the devices to the patients when they're leaving our hospital. Bear in mind, these devices and peripherals could be pretty clunky that these patients have a 5-story walk up to get up to. So it's like trying to outsource that and figure out what's the best solution for our patients, because it is tough. You have people in the Upper East Side who has access to care on their fingertips, and then you have people on the Upper West Side who have these barriers of seeing providers.
So a big portion of why we're here today is to talk about reimbursement. I'm curious how telehealth and reimbursement policy affects the things that you're doing in your program.
So we've been fortunate enough, and I know we said before that we have a CEO who believes that reimbursement should catch up with us. So we had the resources and the support behind us to develop a framework or an infrastructure to develop a telehealth program. So when reimbursement does finally catch up with us, we'll be in a better position. But even still, as we're seeing these changes, for example, mobile stroke units. So we know in 2019, we'll get reimbursed for telehealth visits or for stroke patients. But that stroke visit is very, very small compared to the other expenses that goes into having a mobile stroke unit. So we have a CT scanner on board. We're administering TPA. That's really the most expensive part of taking care of those types of patients. So we're getting there very, very slowly, but we're not really kind of seeing that effect. And I'm not sure how quick we're going to see that in 2019.
So there's a patchwork of things that are covered and not covered. Are there certain telehealth service lines that it's been easier to get reimbursement for, and maybe some that have been harder?
Again, it's being creative around what's out there. So we get reimbursed for psych follow-up visits. We also get reimbursed for our express care patients that come through our ED and that we're fast tracking because we're still able to drop a facility fee. So those types of cases we are still getting reimbursed. So it's being creative around, still taking care of our patients because it's the right thing to do, and not just focusing on areas that you don't get reimbursed, but also looking at other opportunities.
So when you can't get reimbursement, how do you cover that? What's the approach?
So I did mention for our follow-up visits, most of them are not reimbursed. For Columbia and Cornell, since most of our doctors are hired under those buckets, we have a block grant or a special funding for them, at least until that reimbursement catches up with us. And we are starting to see things change. Some payers are reimbursing visits. There's just not a standard process in place. So we do have that, and we're working with our 2 schools to make sure that the providers are still incentivized to block off time and see their patients.
Do you see, because of the area you operate in, you're not just in New York, do you see that being exacerbated by the fact that you're in New Jersey and other places?
Yeah, it's a big issue. We have over 8,000 physicians in New York Presbyterian, and especially our physicians at Columbia, because they're just right on the other side of the bridge to New Jersey, so a lot of their patients are located there. We restricted it to just see their patients that are located in New York. We have looked at other ways for our urgent care, where we took a small pool of providers and we licensed them in multiple states. But it's impossible to try and cover 8,000 providers and have them licensed in multiple states surrounding New York.
If there was one thing that you could change with respect to reimbursement as a policy idea, what would it be?
I think the biggest one is the location of the patients, and not just focusing on rural areas, but also urban areas. I think that would definitely help us in terms of the breadth of our follow-up visits. Yeah, I think that's the one priority, I would say.
So on the slide you showed, I noticed, I think you said 46 states that you've done second opinions. You mentioned 8,000 some odd physicians that are employed. So how do you deal with licensure in covering such a, I mean, you're effectively doing practice everywhere. And for those that don't know, at America Well, we have this thing called the Exchange, where we make New York Presbyterian providers available to people coming in off of other programs. And so how do you handle that?
So the diagram that I showed for the 46 states, that's for a second opinion program. So because we went through a third party, that we were able to kind of offer those services, and we have around 400 providers offering the second opinions program. It's a smaller subset when it comes to urgent care. We kind of looked at our admissions and where people are geographically located. And the big areas were Connecticut, New York, New Jersey, and Florida.
And so do you provide any services to those places?
Yeah, so we got those subsets. Yeah, we got them licensed in those 4 states.
Got it.
Yes.
So you do cross-licensure?
Cross-licensure, but it took a while. It was like 6 months just to get licensed in a state,
So, over the past few years, we've made some progress, right? CMS has just changed the proposed rule on Medicaid Advantage. We've seen a lot of efforts to convince CMS, and Seema Verma talked about this a little bit today, that we think telehealth services should not be considered separate. I'm just curious how you guys think about that. I mean, you obviously don't have a health plan, but how's that impacted you on those services?
So I think in our minds, it's just having a one standard of care and treating our patients the same, whether it's inpatient or virtual. So if you're looking at the continuum, making sure that patients are not, or I guess are kind of not getting the care that they need to just because they can't. So offering those resources to the patients, I think that's how we're just looking at it, and it's just the right thing to do. I think the way we're kind of coming into play, especially as we're looking at kind of saving or cost saving around everything that we're doing, is just efficiency of care as well. So it should be just one standard of care, regardless of whether it's virtual or telemedicine or whether it's inpatient.
How have your patients reacted to the availability of these programs?
Yeah, our patients love it. Most patients love it. I think when you're kind of looking at the types of patients that are coming into the kiosk and into the app, and they don't have to leave their house or their home, that we're getting great feedback from them. Ron called. We actually had an interview with him on NBC, and Ron calls our doctors Dr. Kiosks now, right? Because it's just something that patients didn't know that this was available. I think we're still struggling of getting the awareness around these offerings. And then just communicating to patients of what this service entails. I think that has been a huge thing that, you know, we have found in terms of educating their patients. Because still patients don't know what a telehealth visit is right now. Even if you come into our ED, it's a very, very busy place. If they come up with a screen and they're virtually seeing a doctor or a pharmacist or a nutritionist on the other side, they're like, what is this? So it's like having to explain what is going on and what the benefit is for the patient. I think that has helped us as well. Because if we're telling the patient, oh, look, we're speeding up the process here, you're going to get out of the ED quicker, they're like, oh my God, this is excellent. Who else can come on the screen? So it's just it's figuring out the patient population and knowing what they want.
Dr. Evans and others talked about differences in age for adoption. Do you see any trends on who's more likely to adopt it or not, or does everyone seem to access the service?
I think for our more urgent care, and this is for the patients who hear about this service and who may not necessarily be our existing patient, the average age is around 30 to 40. But once the patients actually come into our facility, it's very, we don't really have an age gap of who's using this more, because even if it's the elderly patients, they have a caretaker, they have someone with them, a daughter, a son who's able to communicate with us, and they're enjoying the technology. So it's really everyone who comes into our facility. We don't discriminate by age.
So we talked about some of the difficulties with reimbursement. And clearly, you've decided to offer service lines that don't have that reimbursement. I'm curious where else you're seeing offsets in utilization or otherwise to justify this, where you're seeing ROI.
Yeah, and I think I mentioned, doing the virtual workup when patients come into RED. Like as we're reducing the time that a patient spends in the ED, that's really where payers are actually saving money. We're not, we're getting patients out the door quicker. So there's some of the areas as we're kind of making the workflows efficient that we are saving ROI. Most of the times we're really not. There is a lot of investment that comes into place, especially as we're looking at like scaling this out and follow-up visits and urgent care visits and dedicating physician time. How are we actually incentivizing and paying for doctors to have these visits even though they're not getting reimbursed? So it's weighing up the pros and cons of where we're saving money versus where we're losing it.
One of the thoughts that struck me from, I think, the last discussion we had, we talked about the triple aim, and lately I've heard that expanded to be the quadruple aim, this idea that we also need to help improve the work life of healthcare clinicians.
Yeah.
Are you seeing anything like that with your providers? Did they like to use this? Did they find benefits of this?
They do like to use it. Our providers actually feel that they get more one-on-one time with their patients, especially our ED doctors, because if a ED doctor is going around the emergency room, it's very busy, there's so many noises, they probably spend 1 minute with their patient and they're moving on to the next. Whereas now they're actually looking at the patient's home environment, they're able to actually assess and treat the patients better. And then also kind of weighing up their work-life balance is that we're offering these shifts so providers can see patients from home. So that has been a huge win for our providers as well. And sorry, just kind of going back to your question around some of the ROIs, because we do a lot of peer-to-peer, that we have the 10 sites, that even just having one specialist cover multiple campuses, that's where we're saving money as well. So we don't have to have physical specialists at each of these sites all the time.
It can take a little bit of time to get 3 miles in Manhattan.
It can take a little bit of time to get 2 minutes or 2 blocks in Manhattan.
2 blocks.
So.
That's fantastic. So I want to make sure we leave time for some questions, but as you think about your experience in telehealth, are there any other policies or things that you would particularly be passionate about seeing change to help advance telehealth?
Yeah, I think originating site, we're excited to hopefully see that come into play. Behavioral health especially is something that we have right now. It's more in school-based, and we also have it in our hospital. I think everyone is talking about that. How do we offer that to patients? And we're kind of we don't even have the psychiatrist to kind of stand up to see patients. So kind of if we're looking at more kind of reimbursement and incentivizing any specialist, I think that's an area that we kind of need to look into.
Fantastic. I would love to just open it up, when we've got folks that have this experience. what questions do you have that we can ask of Shauna about how they're doing things at NYP? And I think we've got a mic here that we can rove around as well.
I was super impressed with the less than an hour visit to a psychiatrist. Will you explain that process and what type of visits are the psychiatrists doing?
Sure. As I mentioned, we have 10 different hospitals. So a patient may come into a Westchester facility into the ED. They need a psych eval. We don't have any psychiatrists on site. So we would have a psychiatrist, we'll say, at our Columbia campus, and we're connecting them through our Vizia, actually now American Well platform. So they're able to do it pretty much in like 30 minutes. They'll take the call and then a psychiatrist will connect with the patient.
Other questions right here?
I saw the e-consult button as one of your NYP on-demands, and I guess first of all, I'll compliment. We love and copy all the time the concept of your board of on-demand. It's a really clear suite of services. But can you tell us a little bit about the e-consult, given that you have a lot of specialty providers from your schools, and how you're maximizing kind of the practice of maximizing their license both for the specialists and then however you're delivering that out?
Yeah, that's a great question. So for the e-consults, I think the icon was more the asynchronous through our second opinions. But you actually mentioned, so we've actually 9 different EMRs at NYP, so it has been a bit of a challenge to streamline and centralize that process. But our Cornell doctors are actually using Epic, and they're going to be launching the e-consults as well. That's something that they've expressed in doing. And that's kind of where we're having difficulty trying to standardize everything, because we have one subset of doctors using Epic, we have everyone else using American Well, so it's been kind of a struggle trying to get the one workflow in place. But yeah, the e-consults is what they're going to be doing along their peers. And I thought the dermatology one was really interesting. We have not even thought of that yet.
Other questions? Right here.
I heard you say that about, I think it was 24% of the consultations that you receive result in an actual change in therapy. And one of the concepts that's attractive to me, and remember I have a hand in the commercial insurance industry, is the concept of a virtual center of excellence. And what I'm struck by is the relationship of what you just reported to Walmart's experience in using actual centers of excellence and shipping patients. And this is Anathema Health Systems, I realize that. Shipping patients off to, unless you're a center of excellence, like Geisinger was for Walmart for neurosurgery. But their experience with that was that there was a huge amount of intervention that simply was not necessary. 30% plus of knee surgeries, stent placements, spinal fusions just weren't necessary. But rather than ship patients off to a place like that, as a commercial payer, I would be interested in, gosh, could we create virtual centers of excellence where you get a consultation with somebody? Have you guys discussed that concept at all at any level?
It is.
Chris, you too.
No, it is an interesting concept. I think for our program, it's more for serious cases where it's that we would have to take the patient if it's a surgery, if they need to come in. For example, we had a patient that was somewhere in California. They were diagnosed with cancer and recommended to go to hospices. So with that second opinion, that they were able to actually transfer, and they actually came over and met with one of our top specialists and had surgery, and they were on the road to remission. So I think for those, lower acuity cases, it makes sense to have this virtual center of excellence. For, I think, the more serious cases, that these aren't just a kind of a quick change in diagnosis. This is intensive kind of research into it with our top specialists at Cornell and Columbia.
Can I ask one follow-up to that? Yeah. Because typically what we've seen, and our system is no exception. I mean, Banner wants to be good at everything, right? And so Stanford's going to say, well, we're a center of excellence for everything, and NYP is going to say the same thing. Probably that will have to be externally vetted at some point, but do you have areas where you are so good and nationally recognized as being so good that you actually put focus on those areas and say, this is what we're going to take to the market?
That's a really interesting idea because I think, there's different specialists across all health systems. I know cardiology is one that's very much recognized at Columbia. But I think taking all these different expertises and having this kind of centralized way would be interesting to see.
And I'll talk to that just briefly. From our view at American Well, where we see this, we have customers that end up with, so think of Cleveland Clinic, where they have various specialties and they will enter into partnerships with other areas to propagate their supply, as it were, in other accounts. And we're doing that with NYP in some areas as well. It's much easier in lower acuity if I can do it straight to the home because of licensure. Our biggest challenge is if I had, the best neurologists in the world at NYP and I wanted to use them, at Banner as an example, licensure becomes a challenge. We do think that's simplifying. We think that the systems are being put in place so that we can start to do that. And obviously in a community health system where they wouldn't claim that they were the specialist in all things, we're seeing absolute demand for that. So the reason I share that is for those that come from those systems that have those great specialists in-house, you should be thinking about that point in time. Because as NYP has been very aggressive about saying eventually it's going to catch up, the technology is there to do that today. We have brokerage systems where we could say, if Intermountain had an area where they needed a gap, let's say they needed child psychologists and we had them at NYP, we actually could broker that conversation. And we actually think with the progress that Krista and team are doing on licensure, on payment programs, et cetera, that will be our future very soon. And so I'd encourage all of you to keep looking at things like that. Other questions?
Do you think your medical records process and your documentation has suffered? It fears me that folks like Drug Commission have not caught up to the process yet and may come retro for 2, 3, 4, 5 years. You think your documentation's there, and particularly when it's between your facility and another facility?
Absolutely, and that's something that our physicians constantly requested for scribes. So we have put scribes in place, especially if providers are seeing like 4 patients an hour, they're not able to keep up with the documentation. So just adding these additional resources for providers and incentivizing them to do this, that has also helped. And again, different EMRs are very different. So we've seen, some hospitals have taken to this a lot better than others, especially if you have, let's say, I'll take our psychiatrist, for example, who's at Columbia, and they may have to cover multiple sites. You have like Cerner, you have Meditech, they're on all scripts. So trying to do that integration between the EMRs, that's something else that has been a bit of a challenge. But for the providers who are just constantly seeing patients and are on dedicated shifts, we do have scribes in place for them.
I'd love to get one more other good question here that we've got.
Okay, I'll ask the last one.
Krista.
Okay, not being a practitioner in the field as a policy person, we hear about stickiness and keeping patients in your system and coming back to your system. Do you find that that's a good argument internally? If you're not getting reimbursement, you might at least be getting patients to stay with NYP.
Yeah, absolutely. And that has actually been a concern for some of our leaders, is that we're offering this service, but if someone is calling for a fever or colds, they're not going to come back and they're not going to come to see one of our primary care providers, or we're not sticking to them to our hospital. We kind of seen the opposite, I think, especially around our urgent care, and we're continuing looking at ways to improve that. Once patients they're in our EMR and they're registered in our system when they even just have an urgent care visit. So trying to give them, trying to educate them on different ways or different channels to come into our system is huge, especially as you might have a patient in Queens. And we're still working on this. This is definitely nothing that has been finalized. But if you're a patient in Queens and you're using our urgent care services, we can direct you to a primary care doctor that's 10 or 5 miles away from your house. So I think we're kind of at that advantage where we're spread out across the city, that we can offer them to a closer facility, because nobody wants to travel in New York. It's all about convenience and consumerism. So just having more options available to them has something that has an opportunity within NYP.
Thank you so
Good,
much
thank
for
you.
the insight. I mean, I would just close by saying this insight that we get from many of you come from great health systems. You know, we heard from Chris today, we heard from Dr. Evans earlier. These insights are absolutely critical, and I'm sorry, Krista, I'm going to steal some of your thunder. Having been part of the Alliance for a long time, I can tell you we need your voices. The way that Stanford is doing things, and NYP and Intermountain, these are all a little bit different. You know, what MedStar is doing and others. So please keep that insight coming. I think what we heard today from Seema Verma and from others is there is a willingness to listen, and I've been amazed at how much we've been able to tilt policy to go towards the things that make sense. And so I just want to thank you all for being here today, and I really want to thank Shauna for
thank you
spending the
having
time
me.
to share insights and for the great questions. Thank you all.
Thank you.
So as much as I love to talk about public policy, I know it's a long day. So thank you for sticking it out. So before I see if anyone has any questions about the policy, I want to mention a couple things. One, thank you again to our sponsors, Intel, MD Live, and American Well. Thank you very much for making this possible. Our website, I'm going to try to have all the slides up there by tomorrow. I know a couple of our speakers still have to get clearance to put it up on the site. So if you don't see all of them there, that's just the clearance process of someone else's process. And then again, the webcast will stay up there. Chad Elamati from the University of Michigan Health System. I don't know if you had a chance to meet him before he had to leave, but he said, can we create a best practices or information sharing network among hospital executives who are working in telemedicine? And I think he enjoyed hearing from his other fellow hospital systems. So the Alliance for Connected Care is happy to house such a network, but you guys, have to help build it if we want to continue this. So if you do want an information sharing group, we could do maybe quarterly webinars, phone calls, things like that, where we can take different subject areas that are vexing, that maybe some folks have answers to or at least experience in. So I told Chad to go and wrangle his health system colleagues, but if you want to get in touch with me too, I'd be happy to try to coordinate something like that. And then also I just want to mention, we're going to be doing a lot of advocacy in 2019. We really got to get that last mile. And I guess that's sort of a pun or metaphor, because broadband is also going to be part of that. But really, we need to get fee-for-service reimbursement. We need to build on some of the successes that we've had. So if anyone wants to get involved in advocacy, I know that your government affairs folks internally are dealing with, a lot of incoming on really big bottom line issues, like site neutral payments and 340B. But if you don't find that your government affairs folks have the bandwidth to focus on these proactive type of policies, you're welcome to come and join the Alliance. And if you are coming to town to do advocacy, if you want to get in touch with me and talk about your talking points, at least we could coordinate a little bit, because I think this is going to be another exciting year for great developments in telemedicine policy. So those are my housekeeping last closing remark items. For those of you who feel like you've had enough, you're free to leave. For those of you who want to talk a little bit more about the sort of nitty gritty of the rules and regulations, and I know, we touched on a lot, but it was sort of up here. And if you have any kind of operational questions about what this stuff might mean, I will be happy to field any of those questions. And again, if you want to ask me next week or offline when you've had time to process some of that, that's fine too. I figured everyone would be tired. Oh, Lyle.
I think we've talked a bit about the barrier of licensure, et cetera. We haven't talked about the compact yet. We know that it is not perfect. It's not nearly as done well as some other things. For example, even with compact, if you get whatever 10 or 20 states, if there's an issue in one state, it can corrupt the other states. Curious if and how much you can comment on that. Thoughts on improving that? Is that I'm not even sure, is that done at it's a state by state level, is there a federal component to it? Love to hear your thoughts on that.
Okay, so is Sylvia here? Okay. We'll talk later, sister, because you're not going to like this, but maybe. Okay, so 5 years ago, the Alliance advocated on licensure. And during that time period, the answer that we got from Congress was, well, the Federation of State Medical Boards is setting up a compact. So let's see how that works. And so we lobbied FSMB, in fact, going as far as, in fact, MD Live's general counsel and a couple other telemedicine general counsels and I flew out to Colorado for the annual FSMB meeting where they were talking about the compact to try to get them to do a reciprocity agreement like they have with the nurses and the physical therapists. So if you're in the nursing compact, you can practice in the state in which the patient, the patient doesn't have to be in the state in which you are, as long as you're in a compact state. So you have a sort of a mutual recognition or reciprocity agreement. That's not the way the FSMB went. They require that you still have a license in the state in which you're operating. And that means you still have to get a license in, 25 states if you want to be, focusing your entire time on telemedicine. So, but the argument on their side was, well, we're just going to make it so easy that you can get a license in, a few days or quickly was the expedited way. So the problem is you still have to think ahead about knowing where you're going to treat patients. You can't just accept a visit from a patient without knowing ahead of time that you're going to need to get a license in New Mexico or whatever. The other problem is a lot of the actual medical boards that are feeding into the compact don't have the technology themselves to facilitate and expedite these licenses quickly. And then the FSMB has had some technical challenges in setting up the technology framework for the compact. So I would say that what we did 5 years ago was say, okay, fine, we'll see how the compact goes. So if we feel like the compact is not working and it's still hindering telemedicine, we have to gather the data for that, tell the story on Capitol Hill to say if licensure is a barrier that either the compact needs more money, the compact needs to be federalized, or we need to have reciprocity agreements, or we need the feds to stand in and talk about licensure. I mean, it is a time that we could bring this up again. I think we've waited long enough to see how this worked, but I'm going to give Sylvia a chance to speak because I know the American Medical Association has an opinion on this and they have a very strong voice on Capitol Hill.
I'm actually glad you did this. I'm not upset at all. So we are in agreement that the technology needs and the speed has been inadequate. We did assign a team to work on the compact adoption. So 24 legislatures within 2 years adopted the compact, and we're on pace, we hope, to get the rest within 2 years, 3 years max. We don't run the FSMB, and there's no press in the room right now. Is this being videotaped? Okay, so I want to be clear about something. We represent physicians. We do not represent the medical boards. We do believe, however, there is value to state-based licensure, and an effort to nationalize or federalize licensure at this juncture would disrupt settled case law at the state and would create a lot of ambiguity about provider liability. We mean health system liability if their providers operating in different states. You would have to federalize a lot of state medical practice laws like abortion laws, end of life laws, minor consent laws. We think that's a lot of work for what really we think is a lack of technology and infrastructure solutions. So, full disclosure, Krista and I had this discussion, I think 4 years ago. We thought that it would be prudent to ask for a substantial amount of funds for the FSMB from Congress in order to give FSMB and their state medical boards enough money and resources to support technological solutions that would ensure the speed of the validation and processing of licenses within those compact states. Our suggestions were declined by the FSMB at the time. And so I think we need to revisit the discussion with the FSMB, and I think it would be very helpful with your members and technology companies to discuss with them what is really an urgent need at this point, that we need to take the reciprocity, it's not reciprocity, take the compact agreement in all of those states. And for those who lack the capacity, the infrastructure, the architecture to do the validations rapidly, I think we can insist on a timeline for making that a reality, because I think the alternative, as elegant as and simple as it sounds, it actually isn't. And I'll just share one more observation. We actually have a lot of experience as an organization with a national enrollment program. It's called Medicare, and we spend a tremendous amount of time in our group working through some of the enrollment challenges we have in the Medicare program. Doing that for 900,000 physicians, or even a third of them, would be tremendously costly and difficult for us to do. So we would like to use technology and your influence to bring to bear a market-based solution that helps increase the mobility of our physicians.
Question over here.
I'm on the finance side, so please forgive me. Question for anyone actually contracting. Medicare, we know what they will pay, will not pay. In our states, we know what Medicaid will and will not pay. I think the most computer savvy population still works. Has anyone had any luck contracting with managed care plans or just third-party commercial payers in general, so we can get some coverage from them as well? I was just wondering if anyone's pursued that with third-party payers.
That Chris has.
I can give a little commentary there, which is we have most of our contracts remain silent on any type of virtual language. What we do see is that a lot of the payers put in their hospital operations manual some detail about virtual care, which from a health system perspective is not ideal because they can update that ad hoc whenever they want and change it constantly. So we have approached some payers around contracting, but to be completely honest, I think both sides are a little bit of fault in that they oversize the value of virtual as a bargaining chip, and it becomes something very complex in what is a very complex exchange of many different rates of, for different service lines or whatever else you're looking at. And as a result, it's kind of left as silent. So the short answer is no, but I will say that if you're in a state where you have parity or certainly reimbursement, or sorry, if you have coverage or reimbursement parity, if you're billing for those, my guess is you'll get a reimbursement on a majority of the cases. That doesn't mean that if you start doing a couple thousand that you're not going to get clawbacks or denials, but that's what we've seen.
Hi. Just in terms of the virtual check-ins that's going to come into play in 2019, is there any clarity on the type of provider that can get reimbursed? Is it just a physician, or can we put on any caregiver like a
Medicare enrolled provider.
Okay.
All right. Well, we're available if you have further questions. We really appreciate you coming, and please be safe. It's still really messy out there, so be careful, and thanks again. Appreciate it.